start, the better. But thank you so much for joining us today, and happy Friday. My name is Alex. I am a cancer genetic counselor here at Yale New Haven Health, and I'll be acting as the host for today. So we have some amazing speakers who have worked really hard to put this all together for you. So we're excited to be here, and we certainly hope you find this helpful. But our goal today is to provide a more 3D understanding of the genetic counseling field. And in reality, this is a big ask because we're a very diverse and multifaceted profession. So that's why we have a very busy schedule, but we'll start with the first half, which is an overview of genetic counseling. We'll have some genetic counselors speak about different specialties within the genetic counseling field. That's before we take a little break in the middle and moving on to the second half, which is more so about genetic counseling programs, graduate school, hearing from current genetic counseling students, et cetera. And there will be a final Q&A session at the very end. Over the course of our day, you will likely have some questions. So we do encourage you to utilize the Q&A function. But if you joined us last year, it's going to look a little different. So if you ask that question, the questions will be picked out by the moderator to pose to the speaker at the very end of their talk, instead of addressing every question in the Q&A function, just so people can more so focus on what is being presented. This might mean that not all questions will be answered. However, our speakers have been very gracious to share their emails, and I'll put that slide up at the very end. So if there isn't a time to address your question, we'll have the Q&A session at the very end, as well as the speakers' emails as well. So sometimes the speakers will have a question for you guys. So keep an eye out for the polls and be ready to answer those. And whether you're able to attend for the full day today, whether you're able to attend for maybe some of the day or not at all of the registrants who signed up for this event will be sent a short survey in maybe about a week's time. And once you complete that survey, that will take you to a recording of the event. So thank you in advance for answering those questions for us so we can help improve this event for future years. A little bit about me. Now, I graduated back in 2017 with my Bachelor of Arts in Biology and Society. I knew that I wanted to be a genetic counselor, so I felt that that really bridged both the science and people, which is what I liked about the genetic counseling profession. Then I went into my master's program at the Icahn School of Medicine at Mount Sinai in New York. And my first job and current job is working as a cancer genetic counselor here at Yale New Haven. So when I tell people that I work as a genetic counselor, almost always they will ask me, what is a genetic counselor? And I think genetics has always been a hot topic, whether it's in the news or sci-fi. So hopefully today, over the course of our session, we'll be able to take a better look at what a genetic counselor is in reality. And I always say that it's not rocket science. So if we think about genetic counselor and break it down, we have genetics, so thinking about DNA, genes, chromosomes, and then we have counseling, implying conversation, conveying information, maybe eliciting feelings about that information, etc. Now, at the most basic level, then, a genetic counselor or genetic counselors are healthcare professionals with advanced training in medical genetics and counseling who educate, guide, empower, and support patients seeking information about inherited diseases and conditions in order to provide a better understanding of how genetic information impacts patients' lives and the lives of their family members. So it's a long-winded explanation, but we wear a lot of different hats. There's no other way to put it, but really this is a profession that was born out of the understanding that genetic information can be sensitive, It can be confusing at times and personal always. So a genetic counselor can help patients navigate this path. And they might talk about whether genetic testing is right for a patient. That might mean explaining the genetic test results and what they mean for the patient and their families, identifying resources for the patients afterwards, etc. It might also be helpful to think about what a genetic counselor is not. So genetic counselors will typically have a master's degree, and that focuses on both clinical genetics and counseling skills. Genetic counselors, or GCs, can work with patients, or they can work with doctors, or they can work independently. And this is compared to a medical geneticist or clinical geneticist who have an MD or MD equivalent degree and specialized training in genetics, meaning maybe they did an additional fellowship in genetics after completing their residency. They also have a specific board exam that they have to pass. And unlike genetic counselors, they're able to perform a physical exam. They're able to perform procedures and diagnose diseases. A laboratory geneticist, on the other hand, is someone who has maybe an MD or MD equivalent degree. They might have a PhD, and they're working more so behind the scenes, so either with the testing technology itself or the interpretation of the findings. But altogether, genetic counselors, medical geneticists, laboratory geneticists, they work together to utilize genetic testing as part of someone's overall comprehensive medical care. But back to genetic counselors. So we're thinking about education, helping with diagnoses and helping families or individuals cope, providing that psychosocial support, advocating for patients, and contributing to risk estimation for inherited diseases. But if you've Googled genetic counseling in the past, you were likely inundated with different acronyms. So I wanted to break that down a little bit here in the ABCs of becoming a genetic counselor. As I mentioned earlier, genetic counselors obtain a master's degree in genetic counseling that typically lasts for about 2 years. And that is from a program that's accredited by the Accreditation Council for Genetic Counseling, ACGC. Currently, there are 57 training programs within the United States and Canada. And as I mentioned earlier, it's usually classroom-based as well as clinical rotation. So going out and working with genetic counselors in the field, helping conduct sessions, etc. Once someone graduates from one of these accredited programs, they sit for a board exam that's put out by the American Board of Genetic Counseling, or ABGC. And that's offered twice a year, so once in February and once in August. And once someone passes that board examination, they get the title of Certified Genetic Counselor, or CGC. About 90% of genetic counselors hold that CGC certification. And depending on where someone goes to work, they might be required to obtain a state licensure as well. Here in Connecticut, that is something that we have to do, but it's just a matter of providing the appropriate documentation that you are a legitimate genetic counselor, you have the appropriate training, as well as paying a small fee. And about 62% of genetic counselors have one of these licenses. Compared to some other professions, the genetic counseling field is relatively new. And the first genetic counseling program was founded at Sarah Lawrence College in 1969. And since then, there have been many important milestones in the development of the genetic counseling profession. So our first professional organization was founded in 1979. That's the National Society of Genetic Counselors, or the NSGC, which you'll be hearing me reference multiple times throughout our talk. And also, of course, moving on from the first professional organization to obtaining state licensure. In 2002, Utah was the first state to provide licensing for genetic counselors. And in 2022, about 31 states, last time I checked, offer one of these, offer licensing for genetic counselors. So first poll for today, let's see if I can access that. How many certified genetic counselors are there in the United States? So this is your closest estimate as of 2021. And I'll give maybe 10 more seconds or so to get your answers in. Okay, so most people were on the nose. Most people said B, or 5,500. About 61% of you said that, and that's correct. There are currently, I want to say, 5,629 CGCs within the United States. There are maybe 2,000 or so practicing genetic counselors outside of the United States, according to a 2019 paper, but yes, about 5,500, so good job. And this is a profession that has continued to grow. It's grown 100% since 2010, and the projected growth rate for the genetic counseling profession is about 21% through 2029. That's compared with a 7% average growth rate for all occupations, which is very reassuring to see. Now, this is a profession that has been named one of the best jobs by US News for several years. The NSGC puts out a professional status survey to their membership, and 9 out of 10 genetic counselors who responded to that survey reported that they are satisfied with their job. And this satisfaction can come from a variety of different reasons, whether it's from intellectual stimulation on the job and or working with patients, etc. And you can see the variety here. A genetic counselor can work in different areas of practice as well. So the traditional role is direct patient care. So working with patients perhaps in clinic, working in education and teaching of genetic counseling. And about 51% of genetic counselors work in direct patient care roles. That's compared to the 27% that are in non-direct patient care. So maybe a genetic counselor is working in a laboratory as part of their variant curation team or even customer service. And 22% of genetic counselors have the best of both worlds. So maybe doing working with patients as well as research on the side. So a 50-50 split. Most genetic counselors are working full-time, and the majority have worked remotely as part of or all of their position in 2021. Genetic counselors can also work in different specialties. The majority of genetic counselors are practicing in cancer genetics, followed by prenatal or reproductive genetics and pediatric genetics. They can also work in different settings, whether that's in the laboratory or in the hospitals. And we're lucky to have a lot of speakers from these different specialty areas joining us today. Some people are practicing in multiple areas at the same time, all with the same genetic counseling degree. But I don't know how these people here are doing 4 or more practice areas at the same time, but there is variety and flexibility to a genetic counseling degree. The good old-fashioned way is working in person when providing direct patient care, so meeting with someone in clinic. Nowadays, especially with the onset of COVID-19, we've been utilizing telephone or web-based service models, less so group counseling, understandably. but it makes it a little easier when we're able to obtain a DNA sample through a saliva sample, which can be collected at home. A blood draw, of course, is a little more difficult to collect from home, but we'll talk about that a little more later. And genetic counselors are very flexible, so they're typically utilizing multiple service delivery models for their patient care. Thinking about salaries, which is of course an important factor when deciding whether this is the right profession for you. The average salary, according to the most recent professional status survey, the results were just released May 3rd this year, but the average salary is approximately 102. But it's important to note that that can vary significantly depending on your role. So whether you work in a direct or non-direct patient care position, where you're located, geographically speaking, as well as your number of years of experience. The average starting salary for a genetic counselor out of school was about $78. And as part of that professional status survey, the NSGC also asks about different demographics to get a better sense of the representation within the profession. At this time, the majority of respondents identified as female, about 10% of respondents identified as non-white. Almost all respondents reported they speak English, but a total of 51 spoken languages were noted by respondents as well. So recognizing that the diversity within the genetic counseling field can stand to improve, and that as a profession, we need to be supportive of existing minority genetic counselors, the NSGC has prioritized justice, equity, diversity, and inclusion, recently forming a JEDI committee to address these issues. And you can see here, the JEDI committee has identified various strategies to support their goals, including working to recruit and retain diversity into the profession. And the issue of increasing diversity within the genetic counseling field has also been recognized outside of the NSGC. So more recently, the Warren Alpert Foundation has given a 5-year, $9.5 million grant to create the Alliance to Increase Diversity in Genetic Counseling. And this is a program that will recruit and train 40 that is, genetic counseling students, providing full tuition, scholarships, and stipends to cover living expenses during that time. And this will be implemented through the 5 programs that you can see here. In addition, the Minority Genetics Professional Network, or the MGPN, was formed in November 2018 to provide a space for minority genetic counselors or diverse genetic counselors from diverse backgrounds to connect with one another. And they also have a prospective student Slack channel, so feel free to join there. And finally, as far as diversity of nationalities, there is the International Special Interest Group, or SIG, that's also available for prospective international students applying for graduate training programs in the United States. So if you're looking, or if you're tuning in internationally from Canada or elsewhere, this might be a great place to look for additional resources. But let's talk a little bit more about the traditional genetic counseling session, just to give us a backbone before we hear from our other genetic counselors. So keep in mind that this can be very different depending on your role, but basically, or generally speaking, genetic counseling first starts with a detailed medical and family history. So the pedigree or the family tree, that's the bread and butter of genetic counseling. It's used to document many features that are crucial to a genetic counseling session, as far as different generations of individuals, how they're related, and maybe even traits of interest, all in one neat, concise little picture. But instead of using dinosaurs and amoebas, we use shapes. So those who are assigned male at birth are designated by a square, while those who are assigned female at birth are designated by a circle. And a diamond shape can be used for individuals who are gender nonconforming or when the sex assigned at birth is not known. A line through the shape is indicating someone who has passed away. After obtaining that information, we'll use that to perform a risk assessment or the likelihood of identifying a genetic mutation in a given patient. So genetic counselors are professionals trained in science communication, and we typically spend some time during a session to review genetics with the patient themselves. If genetic testing is indicated, genetic counselors can communicate the risks, the benefits, the limitations of genetic testing in order to obtain informed consent before coordinating the testing needed. But genetic testing is not always needed. And there are many different types of genetic tests. So on the left-hand side, those are medical or clinical genetic tests that are typically involving a genetic counselor to some capacity. So we have diagnostic testing, which can be used to confirm, to rule out a genetic disorder. Carrier screening or carrier testing, that is done prior to or during a pregnancy to see if the patient and or partner are carrying a gene that might cause a congenital defect or disorder. There's also prenatal diagnosis testing, which is used to detect abnormalities in a fetus's genes before birth to identify congenital disorders or birth defects. Newborn screening is a routine test mandated by law to screen for a set of inheritable diseases or disorders, such as cystic fibrosis. This is something that can differ between states. And then predictive diagnosis, which is testing for a known disorder in the family to understand risk for that disorder. So for example, if someone has a BRCA1 mutation in their mother, we're doing targeted testing for that patient individually. On the other hand, on the right-hand side, there are also non-medical or non-clinical tests that do not typically involve a genetic counselor, but something that you might hear of or patients might bring to you. Obtaining a sample, it's a bit of a pick your poison option or choose your own adventure here, but usually it's either done through a blood draw or a saliva sample. And finally, insurance companies are increasingly better about covering the top cost of genetic testing, especially when there's an indication such as a personal and or family history that's suggestive of an inherited disease. Of course, if you're ordering testing for a patient, you then have to disclose the test results to the patient. You review information as far as screening and management recommendations or next steps based on those genetic test results. You can help the patient by identifying research or resources for them and for their family members, as well as speaking through coordinating genetic testing and or counseling for at-risk relatives who might also, let's say, have that mutation or need genetic testing otherwise. And at the very end, you wrap it all up in a nice bow and summarize it for the patient so they can have it for their records. So without further ado, now that you have a good foundation of genetic counseling, I'm going to pass it off to Maya. She'll be presenting on her role as a laboratory genetic counselor as the first of our many specialists. So let me see if I can do this properly.
Sorry, just 1 second.
Yeah, take your time.
Okay. Okay. So are you seeing the PowerPoint?
Yes, it looks great.
Okay, good, thanks. Okay. Sorry. Okay. So my name is Maya, and I'm one of the genetic counselors at the Yale DNA Diagnostics Lab. And I'm going to be speaking about what it's like to work for a clinical laboratory in a university setting. And then our other genetic counselor at the lab, Emily Blistine, is going to be moderating in the chat. So please feel free to ask any questions that you've got there. So first, we'll talk about our own backgrounds. I'm a certified genetic counselor currently licensed in Connecticut. I graduated in 2021 from Long Island University Post, and I did my undergrad degree at University of California, Santa Barbara, in biological anthropology, largely focusing on human evolution and human variation. So I was a non-traditional student and took a 5-year gap between graduating from undergrad and then starting at my program in 2019. Out of undergrad, I shifted careers around a few times and then ended up becoming a copywriter for a marketing and public relations business for about 5 years. Worked there up until my last year of graduate school. So I would be happy to speak about my experiences as a non-traditional student later on in the Q&A, or if you'd like to email me. But this was my first job out of graduate school. So I've been working here since August of last year. So now I'm going to let Emily speak about herself and introduce herself.
Hi, everybody. My name's Emily. I am also a certified genetic counselor in the DNA lab and licensed in Connecticut. I graduated from the Brandeis University program in 2021. And my undergrad, I got my BS in biology from Allegheny College in 2016. And so if you can do math, you might have noticed I also had a few gap years in between undergrad and graduate school. However, I took a little bit more of a traditional route, and I actually worked as an accessioner at a combined cytogenetics and molecular genetics lab in between that. And this is also my first job out of graduate school. So I started at the DNA lab in September of 2021. And now I'll turn it back to Maya to talk about our daily duties.
Okay. There we go. So at a small lab like ours, the genetic counselors take on some pretty versatile roles. So my primary responsibility is being a liaison between the ordering providers, the billing and prior authorizations teams, and then the different members of the laboratory, like the lab techs or our molecular geneticists. So as part of my job, I offer post-test support for ordering providers who have any sort of additional questions about the result or follow-up. And finally, we also do interpretation of the data for panel tests, tumor tests, and then single site tests. So we work on variant interpretation for the lab also. So as I said before, assisting ordering providers is my primary role. I take questions about future orders, such as if the lab can offer a certain test. For example, we get a lot of questions about whether we can do testing for pseudogenes where next generation data might not be the best, or for non-sequencing tests. One well-known example would be Fragile X testing, where you're not looking so much at single changes in the gene so much as these repeats. So that's done with a different sort of test, and we do that. It definitely helps to have a strong background and interest in molecular genetics to work at a lab. And you definitely learn a lot more about molecular genetics as you work here. So I also assist in questions about insurance coverage and authorization. The lab has to review certain tests where we can't get authorization from insurance. And it's my job to review the clinical notes from those orders to determine whether the patients meet criteria based on their payer's guidelines. So I do this with the assistance of somebody from the billing team or a coder whose expertise is in actually reading and interpreting the policies themselves. Our lab offers something called virtual panels. So the entire exome is sequenced and we only report on the genes or conditions that the provider specifically requests in the order. So I take calls from our providers or get emails sometimes requesting customized gene lists, or we have set gene lists that we're already using for some providers. And then as a follow-up to positive test results, I'll email providers to let them know about a pathogenic test result before it's reported, or at the same time that it's reported directly to a patient's chart. And I get requests about follow-up recommendations and maybe which other specialties they might want to refer their patients to. And also take any sort of inquiries about existing orders and pending results, such as what the expected turnaround time is or if the test is already in process. So laboratory stewardship is a really crucial part of working at a genetic testing laboratory. A lot of labs are hiring genetic counselors because our training is really focused on selecting the most appropriate tests based on individual or personal or family history of these individuals. So we know how significantly these results can affect patients' future health and management if they do end up getting a pathogenic result. So we need to make sure that the test being ordered is appropriate. And then this also helps with insurance coverage because it can be very difficult to get some of these tests covered. And we want to make sure that whatever is being ordered is going to be the most appropriate the first time, because once you get a denial, resubmitting can be more and more difficult for additional tests. So I review every order that comes into the lab. Some of our ordering providers rely on the lab to select gene lists based on the patient's phenotype or whatever sort of condition or different symptoms they're experiencing. So we are able to customize, as I said before, and we accommodate those requests. And I work with our geneticists to determine what sort of gene list would be appropriate for the orders. Another concern is that providers might simply place the wrong order because they can't figure out which one is the right option based on our lab test menu. We do it a little bit differently here than the commercial labs because we only have a set number of orderables and they order directly through our electronic medical system, which we use is Epic. So maybe they want to place an order for a known familial variant only, but then they selected an extended gene panel because they didn't know that they needed to search for something else in Epic. So they might write a comment about a specific gene. So I would be the one reaching out to the providers after reviewing the clinical information and presenting different test options and making sure that we actually do want to do an expanded test rather than that really targeted test. It's very important that the patient does not receive information that they did not consent to when they were counseled about the results that they would be getting. So Emily is going to talk about one of her roles, which is not directly related to genetic counseling, but it shows how our education and expertise can be applied to different areas. And that's data management and bioinformatics. So I'm gonna let Emily take over again.
So yeah, my position, as Maya just mentioned, one part of it is definitely not a traditional genetic counseling role, but that is something that I honestly really liked about the position when I was applying, and it really just goes to show how versatile what we learn in genetic counseling school is, and how that skill set can be used in a bunch of different ways other than just seeing patients or even the more traditional laboratory genetic counseling role. So the biggest part of my job is bioinformatics and data management. So our lab does a lot of the lab work in-house. So we extract the DNA ourselves, we do the analysis ourselves, we do Sanger sequencing ourselves. But one thing we don't do ourselves is next generation sequencing. So any sample that needs next generation sequencing is sent out to another part of Yale. And then when we get that next generation sequencing data back, it is my job to turn that sequencing data into data that is usable for our analysts to be able to write the reports and get those results back to the ordering providers. And also, when the data is made usable, making sure that it is in an easily accessible location for everybody to find. So I'm the person who, if somebody's looking for something, they come to me. And at first glance, this might not seem like it is super related to genetic counseling, but in this process, I'm also looking over the orders for all of the samples that I'm working with that week. And I'm kind of serving as yet another check after Maya and other people, just to make sure that, once again, the orders are appropriate and there are no issues with insurance. So my genetics knowledge that I gained in graduate school is definitely very helpful for this, and just allows me to serve as yet another checkpoint, because you can never have too many, to make sure that everything looks good with these orders and we're actually getting the providers the information that they want. And so I will turn it back to Maya for the other part of my job, and something that we are both very involved in, which is variant interpretation and report writing.
So as Emily mentioned, both of us work on variant interpretation. So what we do is we analyze the raw data that comes into the lab and follow ACMG guidelines to classify variants. And this is standardized across every genetic testing laboratory in the United States. So we use various databases to back our interpretation. Some of you might be familiar with them if you worked in a lab at all or had any undergrad experience in genetics in a clinical setting. So we use ClinVar, GenoMed, for example, and then our own internal database. So the lab has our own database where we record the specific changes in the gene that we've seen before and the phenotype, or the symptoms that accompany those changes, or what it's been correlated with, because they're not always related, but it is good to have that backup if it's a very rare sort of change. So we also assist the lab directors in reviewing the reports that are ready for sign out. And we check, or we look at the clinical information and make sure that it's clear and is appropriate for the condition that's being reported, and that there are no major errors. For example, spelling errors we try to catch, or if there's any sort of error in the gene name, like, because some of them it's just a series of letters and numbers. It can be really easy to miss those sort of typos if you're staring at that report for hours as you're working. So variant interpretation is a role that a lot of labs are hiring genetic counselors for. And I personally was not aware of that prior to starting my graduate program. And some of the programs do introduce variant interpretation. So for example, at Long Island University, we had a course with one of the major commercial labs, and we had weekly data interpretation assignments. But a lot of the labs are also training genetic counselors to analyze and write test reports because they have their own methods, their own data systems. So they really are just looking for the sort of clinical and molecular expertise that genetic counselors do end up getting through our graduate degrees. So you'll be hearing from some of our other genetic counselors about what their roles are like in a clinical setting. And overall, laboratory genetic counseling is fairly different in a non-patient facing role. So I'm not in a patient facing role, and my interaction with patients is very limited. I will sometimes take calls from anxious patients who are requesting updates on test results, and my psychosocial skills that I've learned from genetic counseling school come into play there. But I also need to redirect them to contact their ordering provider or seek a referral to genetics. So I am not in the sort of role where you would be counseling or speaking to patients. So I do get to see every test order that comes into our lab. I need to review each test order. So I get to learn about a lot of different conditions and what genes might be associated with them, because as I said before, I'm reviewing those orders to find appropriate gene lists if the provider is not specific about what gene lists they do want included. It's a great way to continue learning in the job, and I'm exposed to some really interesting and unique cases. So the skills that we learn in our graduate programs also get applied in new ways. Instead of reviewing clinical notes to prepare to counsel a patient, for example, I'm going to be reviewing those notes to determine what gene lists can be applied to based on the differential diagnosis, or as I said before, seeing if they meet criteria for testing, if their insurance company is leaving it up to us in those cases where we can't get prior authorization. So we also get to interact with a lot of different providers in a system as they're following up with on results or want to learn more about what the result or the test is or what it means. For example, I once received a phone call from a primary care doctor who wanted me to help him come up with a strategy for explaining the results to his patient and advising on following up testing for family members. Because he was an older doctor, he admitted to me that his education in genetics was very basic and he really didn't know how to handle that step. So I really enjoy being able to collaborate with and educate some of the physicians or other providers like nurses or physicians' assistants about genetic counseling, and helping them come up with strategies for speaking to their patients. So Emily's work in bioinformatics also showcases that we get the opportunity to learn new skills that would not necessarily be learned in a clinical setting where we're facing patients. It also shows that genetic counseling degrees can be applied in some pretty interesting and diverse work settings. I think many of us pictured being in a clinical setting long-term when we entered graduate school, but sometimes you find that maybe that's not what you want to do long term, or you want to experience some other areas of genetics. And working in a genetics lab is really a great way to learn to apply those skills that you've learned in a new and different way. And it's pretty rewarding and it's very interesting. So I am going to stop sharing my screen, but I would be happy to take a look and see if there's any questions that we've got in the Q&A. Let's see.
I think there's one, and if maybe both of you would be able to comment on how did you decide, or what was maybe I'm lacking the word now, but what precipitated the decision to move into laboratory genetic counselor after graduate school?
So I can answer first since I'm already unmuted. But it wasn't necessarily a plan for me. I applied to a lot of different roles and interviewed with a few different places, but I really liked just the sort of versatility of this role. I've always had an interest in molecular genetics, so more than just looking at the sort of symptoms and counseling people, I really like knowing what goes into what comes out of a test, basically. Like, how is that data being interpreted to say that because of this sort of genetic change, this is what might happen with this person as far as their health goes. And something about my position is that I will be getting the opportunity to do more of a hybrid position, in that I'll be seeing patients once a week. So that was another thing that I really liked. I wasn't really drawn to a full-time clinical position necessarily, because I do like being in the laboratory setting, but I just love the fact that I could really go in any direction that I wanted to by working at the lab, within reason, of course, but it just allowed me to really look at all the sort of different interests that I had.
Emily, do you have?
Yeah, so I think for me, a big part of it was actually my work that I did before graduate school. So I was in a lab for 2 years and working with laboratory genetic counselors there, and they knew I wanted to be a genetic counselor. So they were really great about like keeping me in the loop with everything that they were doing and kind of showing me the ropes a little bit. And through that, I came to really appreciate just how varied the genetic counselor role can be. Prior to that, I really only had exposure to clinical genetic counselors. So I really found it fascinating that I could be a genetic counselor, but still kind of help behind the scenes almost, not necessarily seeing patients, but with the testing itself. And that kind of drove me to think about maybe going into laboratory straight out from graduate school. And then I also see some other questions, one specific to bioinformatics. So I actually worked with a bioinformatics expert, and he kind of taught me the ropes to do what I need to do. I'm definitely not an expert whatsoever, but I can do the job. And I think the reason that I was hired was they were more looking for somebody who had that genetics knowledge, and they figured it would be easier to have somebody who already had that, like I learned in genetic counseling school, and teach me the little bit of bioinformatics that I needed to know, rather than getting a bioinformatics person and teaching them everything about genetics that is needed for my job.
Excellent. And we do have some other great questions, but I have to be strict about our timing since we have such a busy schedule. So please stay tuned afterwards. When we have the general Q&A, we'll try to answer as many questions as we can. But I think we'll pass it over to Julie for our talk about reproductive genetics. And thank you, Maya and Emily. That was a great presentation. And we've been doing this for 3 years now, and I feel like I learned something new every time. So thank you again.
Great. Hi, everyone.
Julie, let me get you on the spotlight. There we go. Perfect.
So hello, my name is Julie. I'm a reproductive genetic counselor at Yale, and I work in the Department of Obstetrics, Gynecology, and Reproductive Sciences, specifically in the section of maternal fetal medicine. And I frankly could not do what I do without Maya and Emily and the work that they do, because we may be the people in front of the patients, but they are doing the work, as they said, behind the scene that allows us to really provide answers for many of our patients. So with regard to my professional background, I graduated from the Joan Marks graduate program in human genetics at Sarah Lawrence College. I am not going to say what year. I have been working in maternal fetal medicine at Yale for over 5 years. And I would say that over 90%, probably more than 95% of the individuals that I see are considered high risk with regard to either their maternal or fetal concerns or a combination of the two. And I previously worked at 2 different medical centers, and over the years have had the opportunity to specialize in not only prenatal or reproductive genetic counseling, but cancer, pediatric, and adult genetic counseling services. So my jobs have predominantly involved direct patient care. I've also engaged in various clinical research studies, and currently, and with my last job, I would say at least 5% of my position involves teaching. Currently, I'm teaching the maternal fetal medicine fellows. Every 2 weeks, I provide a lecture so that they can be introduced to various genetic topics that will help them when they are out in the field, as well as help pass their board exams. But sometimes I'm called in to speak with nurses, social workers, sonographers, etc., to really educate them about what I do and how I can support their job and their patient population. In the past, I served as the director of clinical training and as a clinical rotation supervisor for students that were enrolled in the genetic counseling program at the Icahn School of Medicine at Mount Sinai. And to date, I have had the pleasure of working with and supervising over 200 genetic counseling interns who were enrolled in various genetic counseling training programs across the US. So I would say they keep me on my toes and make sure that I'm staying on top of everything within my field, which is great. So I wanted to step back and talk about the difference between when I say a prenatal or reproductive genetic counselor, since sometimes you'll see those used interchangeably. But if we start with prenatal, that's really talking about what is occurring or existing during pregnancy, before birth. So prenatal care is the health care that women receive during pregnancy. And some genetic counselors refer to themselves as prenatal genetic counselors because they are either predominantly or exclusively working with individuals and their partners while a pregnancy is in progress. Other genetic counselors refer to themselves more broadly as reproductive genetic counselors because they are collectively working with individuals who are pregnant, planning to become pregnant, or interested in discussing concerns that arose during a previous pregnancy. And genetic counselors have filled an important role in supporting patients to make informed and value consistent reproductive decisions since prenatal screening and diagnostic testing were first possible. So in my specialty, some common reasons for referral include advanced maternal or paternal age, which generally means that someone is 35 years of age or older at the time of delivery. If someone has a personal or family history of a known or suspected genetic condition, intellectual disability, or congenital structural difference, such as a congenital heart defect, cleft lip or palate, etc. There can be atypical fetal ultrasound findings or abnormal prenatal screening or diagnostic results, concern about whether medications, drugs, alcohol, environmental exposures that occurred prior to or during pregnancy may impact fertility or fetal development, pregnancy outcome. Someone might be a carrier for an inherited condition or a chromosome rearrangement and would like to discuss what this means for their family planning. And another common reason is history of recurrent pregnancy loss or subfertility and infertility. And one question that I wanted to ask everyone is, what percentage of pregnancies that result in first trimester miscarriage are found to have a chromosome disorder, which means either extra or missing chromosome material? And this is ranging from the low end of being 5 to 6%, 10 to 15%, 25 to 30, or 50 to 55%.
Oh, we're getting quite a range for our poll answers. We'll give it maybe 10 more seconds. All right, 3, 2, 1. And can you see that?
I can. Right, that's very interesting to see. So the correct answer would be 50 to 55%, which I know is shocking to a lot of people. And this was something that was really flying under the radar years ago before there was testing available on DNA that we receive from cells from pregnancies that have miscarried. So I think, one thing that we try to tell patients when a chromosome problem is identified during pregnancy is not necessarily something that makes them feel better, the fact that this is a common occurrence, but can help them to feel that there's not something wrong with them and that there's hope that they can go forward and have a successful pregnancy. Other common reasons for referral are individuals that are requiring assisted reproductive technologies to achieve pregnancy, individuals who are donating eggs or sperm for these purposes, people who have multifetal pregnancies, including twins, triplets, quadruplets, and more, those with specific ethnic or racial groups or geographic areas with a higher incidence of certain genetic conditions who are interested in having genetic carrier screening for those conditions, and then just general interest in discussing test options that are available for individuals or their reproductive partners prior to or during pregnancy. So this can include things such as genetic carrier screening, testing for chromosome conditions during pregnancy, etc. So as Alex had mentioned, some things that happen during a reproductive genetic counseling session are very common in other settings as well. But typically we are obtaining medical, reproductive, and environmental exposure histories, taking a family history. Depending on the reason for referral, we may go back multiple generations. Other times we may not have the time to allot to that, and it may not be relevant to the reason for referral. So it may be a much smaller pedigree. We are explaining the risk for or the diagnosis of a genetic condition. talk about inheritance, recurrence risks, the benefits, limitations, and risks of test options that people have, prognosis, management, current treatment options, as well as prevention and current research options. We will interpret the results of this testing that they've elected to have, discuss the implications for the current fetus and future pregnancies, and talk about next steps. We will talk to them about assisted reproductive technologies, and we will also try our best to support them while they're making these decisions and trying to, by the way, forgive the sound in the background, that's my dog growling. So we'll talk to them about decision making and try to take into account their personal, their religious, their ethical and moral values, etc. And I would say our biggest goal has to be establishing rapport with patients. The faster, the better, because we can't do the other things on this list. We can't achieve the other goals unless we have established rapport. We'll try to assess their needs, exchange and discuss relevant information that's specific to them and their situation. We will try to elicit their thoughts and feelings. We'll support their autonomy and their decision-making. And we provide short-term psychosocial support and patient advocacy. And we know our limits as well, so that we identify situations where someone might need additional medical referrals or psychological referrals or support services. You know, whether that includes referring them to actual support groups, individual counselors, referring them out to other medical specialists. And we try to serve as an ongoing resource as their needs and their desires evolve over time. And I selected a case that actually took place several years ago, but I thought that it is a really good example of how someone's needs and desires may evolve over time and how we have to pivot with them along that journey. So for this particular patient, she was 40 years old and referred for genetic counseling at approximately 12 weeks in pregnancy due to advanced maternal age. So we know that we learned that this patient and her partner had one previous pregnancy that resulted in miscarriage that happened about 6 months prior to my meeting with them. And chromosome analysis that was performed on the products of conception from that pregnancy revealed that the fetus had a sporadic, meaning not inherited, chromosome condition that is called trisomy 13. So, just rapidly giving a little background, individuals typically have 23 pairs of chromosomes for a total of 46. The first 22 pairs are numbered, 1 through 22, and the 23rd pair are called the sex chromosomes, which are X and Y chromosomes. Most females have 2 X chromosomes, and most males have 1 X and 1 Y chromosome. And chromosome aneuploidy is a term that's given when there is an abnormal number of chromosomes. So for example, there are 45 or 47 instead of 46. Most of these chromosome conditions occur by chance as the result of an egg or a sperm cell that was created with an extra or missing chromosome. And as women get older, there is an increased chance to have a child with a chromosome abnormality. But I would like to point out that this risk is gradual. So for example, someone who is 20 years old has less than a 1 in 400 chance to have a child with a chromosome disorder. And at the age of 38, it has gone up to 1%, but I would like to view that as a 99% chance that there would not be a chromosome condition. So trisomy 13 is considered one of the more severe chromosome disorders, and it can result in miscarriage or the birth of a child who has severe intellectual disability and medical concerns and physical abnormalities. Years ago, they used to think that this condition was universally fatal within the first weeks of life, but now with improved technology, approximately 5 to 10% of children with this condition can survive past the first year. I am going to skip ahead to say that during the counseling session, we were talking about how this usually occurs by chance. This patient was 40 years old, so we talked about that her chance of having another pregnancy with a chromosome problem was not felt to be significantly different than anyone else her age in the general population, which is in a 1 to 2% range. And we offered her some screening tests that can assess risk for some of the more common chromosome conditions, as well as diagnostic tests that permit us to actually look at the chromosomes for the pregnancy under a microscope with over 99% accuracy. And we talked about the benefits, limitations, and risks of both of these diagnostic tests, including the 1 in 400 risk for miscarriage that these tests are associated with. So she expressed that although she would love to have the information that the diagnostic test can provide, she did not want to have a test that had a risk of miscarriage and elected to have cell-free screening. So by the way, the details that I've provided on these slides are really for later when you're looking through them, in case you needed some background to understand what we're talking about. But I am just going to kind of cut to the chase for what happened with this couple. It turned out that she was not able to get a result from the cell-free DNA screening. And that by itself indicates that the pregnancy could be at increased risk for certain chromosome disorders. So we again offered her diagnostic testing, and she elected to have an amniocentesis. And when she arrived on the day of the test, prior to performing the amnio, ultrasound revealed that the fetus had a brain abnormality that is called semi-lobar holoprosencephaly. So the counseling session involved talking to the couple about what holoprosencephaly is, talking to them about the different outcomes that can occur depending upon the extent to which the abnormality exists. And we talked about that this condition is not always genetic. It can be caused because of environmental problems or exposures. It can occur due to sporadic chromosomal or genetic conditions, and it can be associated with some inherited conditions as well. They elected to proceed with the amniocentesis, and the first thing that we found out is that the fetus had the correct number of chromosomes, which is 46. An additional test on that specimen revealed that there was no little pieces of chromosomes that are extra or missing, so that reduced the chance for over 150 different genetic syndromes, only a small group of which could be linked to holoprosencephaly. And then with the help of a laboratory genetic counselor, we were able to determine a panel of genes that would be appropriate to test this fetus for. These genes were all associated with holoprosencephaly, and it revealed that the fetus had one copy of a pathogenic variant in a specific gene that was called ZIC2. And this disorders in one copy of this gene are associated with a condition that's called holoprosencephaly type 5. And in this condition, we commonly see semi-lobar holoprosencephaly. So we felt quite confident that this variant was what caused the fetus to have holoprosencephaly. And we each have 2 opportunities to have this gene working properly. If one is not, then the person would be predicted to be at risk to have holoprosencephaly. But this gene is not fully penetrant, which means that some people with variants in this gene that are considered to be gene disrupting variants appear to have no symptoms or have such mild symptoms that they are never diagnosed as having this condition. So we recommended that the parents be tested, and it turned out that the partner had the same variant. And although we certainly did not have information regarding his brain MRI outwardly, he had no signs of having holoprosencephaly. They were informed that with each pregnancy, there's a 50% chance that the fetus would inherit this pathogenic variant, but that not every fetus with the variant would have holoprosencephaly. And we also let them know that fetal ultrasound may not always show us that a fetus will have complications secondary to this variant. So we wanted to make sure they were aware that they had the option of having in vitro fertilization, where the egg is fertilized outside of the body, with then genetic testing on that pre-embryo to see if it was affected. Or they could have targeted prenatal testing during pregnancy to see whether or not the fetus inherited the variant. And they elected to conceive their third pregnancy via IVF. There was targeted pre-implantation genetic testing for this variant. And they were able to have a successful transfer and implantation of what was predicted to be an unaffected embryo. They elected to have prenatal testing early in pregnancy at around 11 weeks to confirm the accuracy. And it confirmed the fetus was not carrying this variant, and they delivered a healthy baby boy. So this was really a very long haul for this couple to have a baby. It was over 5 years, but it was certainly a wonderful outcome. So in my last couple of slides, I wanted to say that, pregnancy can be a lot of things. It can be planned and unplanned, desired, not desired, can be wonderful and exciting, scary, anxiety provoking, etc. The list could go on. And reproductive genetic counselors have both the responsibility and the privilege of educating, supporting, and working with individuals who are faced with making really difficult decisions, both prior to pregnancy and during pregnancy. And working with this patient population, I can say, has been extremely rewarding and challenging. And I have stayed consistent as a genetic counselor who does reproductive genetic counseling from the beginning. And it's something that forces me to consistently be learning every step of the way. So sorry, I know I ran over by a few minutes.
That's all right. That was a great talk, as always. And I wanted to maybe pose a question to you before we hop over to Sarah's talk about cardiogenetics. Someone had asked about carrier testing specifically, and whether that's doing mostly sequencing of the genome, or are there other ways to test for a carrier? Could you just maybe expand upon that a little bit?
Sure. I would say the majority of genetic carriers testing is being done through gene sequencing. Although for some of the more common genetic conditions that someone can be a carrier for, other technology is actually better for identifying carriers than gene sequencing. So, that is part of our responsibility, is knowing what screening is appropriate for someone in general, and how we might modify that based on personal history or family history or ethnicity. So there's not one straight answer, but yeah, overall gene sequencing is our go-to for the vast majority of conditions.
Well, thank you again, and we'll certainly tab back during the general Q&A, but let me see if I can get Sarah up and running. There we go.
There we go. Yep, I'm right there. Okay, so let me just get this one. Okay, there we go. So hi, everyone. As Alex said, my name is Sarah, and I am a genetic counselor at Yale New Haven Hospital, who specifically works in cardiovascular genetics. So first, just a little bit about me. I am originally a Jersey girl. I'm from New Jersey. I did my undergrad at Montclair State in New Jersey. And then after 2 years, I went back to grad school and I did the genetic counseling master's program at Rutgers, which is a relatively newer program, which was, interesting to be a part of a new program. So I graduated from Rutgers in 2020. So working at Yale, similar to some of the other presenters, has been my first and only job since graduating. So they must have, good retention here, which is nice. So I work more specifically in the Heart and Vascular Center within the Yale New Haven Health System. And again, more specifically than that, I'm in the congestive heart failure program, as well as the inherited hypertrophic cardiomyopathy program. That's the program that my role is specifically built into, although I do see a lot of other indications outside of just HCM. So at Yale, we do have an HCM, what's called a Center of Excellence, meaning that we have a clinic here that is, essentially designated by the Hypertrophic Cardiomyopathy Association as being a multidisciplinary center for patients with this condition, including services such as genetic counseling and assistance with testing and family screening. Okay, so first, just to kind of give an overview of what my role is like in the world of cardiology. Firstly, the people that I work with. There is another genetic counselor who specializes in cardiovascular genetics. And if you attended this talk, a year or 2 years ago, I believe Arpita was the one, giving the talk about cardiac genetics. So if you were here a year or 2 years ago, you might remember some things from her talk. Her and I have pretty similar roles that overlap a lot, but aren't entirely the same. So I work with a lot of different cardiologists, actually. Some cardiologists who are just general cardiologists, and then also specialty cardiologists, including electrophysiologists, so doctors who work with problems with the heart's electrical system, specialists in cardiomyopathies. There are a lot of different types of genetic cardiomyopathies that I'll kind of briefly go over later. And then finally, sometimes we work with cardiologists who specialize in treating patients with advanced heart failures. Additionally, we do work with admins when it comes to, how we schedule patients, how we build out our schedules, some programmatic concerns and things like that. There is a lot of collaboration with laboratory staff, both, here at like the Yale DNA lab or, in some external genetics labs. We send some tests kind of through the Yale DNA lab, as well as some larger like commercial outside genetics labs. Often just depends on things like insurance, turnaround time, things like that. And then finally, I do work with some other research staff. There are a couple of research projects that I'm a little bit involved in. So I often work with, various researchers as well. And then I think a lot of people question how patients actually get to see a genetic counselor. So many of our patients will get referred to us maybe through their PCP. For example, if their general practitioner happened to notice something like a cardiac murmur during a regular evaluation, that's something that might prompt further cardiac workup and potentially some genetic testing. These patients might get referred by a cardiologist if they're already seeing one for something like high blood pressure, high cholesterol. If they identify some other problem that needs more specialized testing and discussion, they might refer to our specialty group. Some patients do self-refer. We do get some self-referrals. If you Google Yale cardiology genetic testing, you'll come to our page, and some patients contact us that way. Also through the NSGC Find a Genetic Counselor tool, There have been a handful of patients who have utilized that to reach out to us, if they feel that there may be a need for genetic testing within their families. Additionally, we do a lot of predictive testing for family members when the proband tests positive for a genetic mutation. So a lot of our patients do come to us because they're related to someone else that I saw previously and provided testing for. And finally, we do some cross-referring here between the different genetic counseling specialties. For example, a cancer genetic counselor might uncover a family history of cardiomyopathy or an arrhythmia, something like that, and recommend that a patient sees, a cardiac genetic counselor for more specialized testing. And then vice versa. We often find family history of something such as a cancer syndrome where we may refer to another genetic counselor in a different specialty. So we do have some collaboration here between all the disciplines. So, and a question I do get a lot from prospective students is just, what does your week look like? Like what's an average kind of week in the life for you as a cardiac GC? So obviously a large kind of chunk of my time gets taken up by the genetic counseling consults. And as mentioned earlier, we do have, kind of different ways we do the consults. Currently, we are doing a lot of virtual phone visits with patients since the COVID pandemic. And then occasionally we do also have in-person consults with a cardiologist in the clinic potentially. In addition to that, a lot of my time is taken up by charting, putting in the visit notes, placing in the orders for genetic testing. And then of course, everything you send to the lab will come back to you. So a lot of time is taken up by reviewing patient results, and then of course, calling those out and discussing those with the patient and their families to make sure that we have a plan for their management. We have a weekly cardiovascular genetics case conference with I and the other genetic counselor and a group of cardiologists where we discuss, interesting or difficult cases. And then finally, on Fridays, I am always doing case prep for Mondays, so you can go into start the cycle all over again. And then outside of kind of the more typical, GC duties, like I mentioned, I do have some research duties as well. I've helped out with a couple projects here and there. I have had the opportunity to supervise some students, which I love doing. I've had some students shadow with me, which was, a great opportunity for someone who is not even too far out of school myself. We do have within Yale multidisciplinary genetic counseling conferences. In addition to that, the National Society of Genetic Counselors has a yearly conference. So occasionally I may be working on a poster for that conference. We did mention special interest groups earlier. There is a cardiac special interest group. I am not personally super involved in it, but it's a great resource. So just something I really wanted to include on the slide. Like I mentioned, a lot of our consults are virtual, but we do also have inpatient consults, sometimes with the patient in the cardiac intensive care unit. We might go, we might be asked to go see them and speak with them about potentially doing genetic testing. And finally, occasionally I might have meetings with more so with outside lab staff to discuss, maybe new testing panels that they are piloting and things like that. Okay, so we'll just give kind of a brief overview of some of the most common conditions that I see. So first of all, of course, we have hypertrophic cardiomyopathy, which is really kind of my bread and butter. I see a lot of this condition. Essentially, it happens when the muscular walls of the heart become too thick, often because of a genetic mutation that someone carries. It's actually a relatively common condition. Probably about 1 in every 250 people may have this condition, according to most recent estimates. And then having this thickness, this abnormal thickness in the heart muscle can cause a couple of different problems, including something that's called diastolic dysfunction, which means that the heart can't relax properly to fill with enough blood. So sometimes there's trouble with blood getting to the rest of the body. It can increase the risk for AFib, which in turn increases the risk for stroke. And sometimes, part of an HCM workup may involve differentiating what we call true genetic HCM from other conditions that can mimic genetic HCM. These are things such as hypertensive heart disease, something called athlete's heart, which can happen when someone undergoes intense athletic training for many years. It can kind of remodel the structure of the heart and make it thicker. And often, the types of HCM that we see are just isolated, but they can be present in different syndromes, as well as part of something, for example, Noonan syndrome. HCM is just one feature of that condition, but it may present with other findings as well. So in contrast to hypertrophic cardiomyopathy, we have dilated cardiomyopathy. As you can see, in this type of cardiomyopathy, the walls of the heart are kind of stretched out and thinner, so it makes it difficult for the heart to pump blood to the rest of the body. There's a risk of developing arrhythmias or other problems in the electrical system of the heart, a risk of progression to end-stage heart failure. Some of the genes that cause DCM may also present with muscular diseases as well. So that's something that we also may want to pay attention to. And additionally, we do get some referrals for patients who have postpartum cardiomyopathy, often from a provider who's kind of an expert in cardiobstetrics. And it's been found that about 15% of women who develop a postpartum or peripartum cardiomyopathy will actually carry a pathogenic mutation for a dilated cardiomyopathy. Okay, and then there's also something called a rhythmogenic cardiomyopathy, which, as the name implies, comes with an increased risk of ventricular arrhythmias, given this sort of fibrofatty and scar tissue replacement of these normal healthy cells in the heart because of the gene mutation that someone may carry. And this is an interesting condition because exercise can actually make it worse. So these patients are often told to moderate their exercise and try, more low impact things like walking or yoga, as opposed to, high intense athletics. And then this is just kind of a quick overview of how cardiomyopathies may be, diagnosed. There's often a lot of imaging done, genetic testing, obviously, blood work. Sometimes patients may present with symptoms such as shortness of breath, chest pain, or heart palpitations. And sometimes people may have no symptoms at all, just those changes inside the heart. There are many different genes that can cause these problems. Some of them may only cause one specific type of cardiomyopathy, and some can cause multiple different types. Most of the inheritance patterns that we tend to see with these conditions is mostly autosomal dominant, but there can be some other inheritance patterns as well. And finally, these conditions are managed through medications, lifestyle changes, sometimes devices, surgery, and then of course, family screening is an important part of the management process. If an individual in the family is identified to carry a pathogenic mutation, we will discuss the option of genetic testing for that patient's family members who may be at risk to also develop the condition. And then just briefly, like I mentioned, we also see, some inherited arrhythmias. We work with electrophysiologists for genetic testing for these patients. Two of the most common ones that you may have heard of include Brugada syndrome and long QT syndrome. In essence, these are EKG changes that may increase the risk of a dangerous heart arrhythmia. So it's something that has to be managed often with medications, or also avoiding any triggers that can additionally cause these arrhythmias to appear. And then just a few more, just kind of round out these slides. Sometimes we see patients for inherited aneurysms, which is essentially a bulging of the blood vessel that you can see here. This is also something that can present as an isolated condition, or it can be syndromic, presenting with other features of a connective tissue disease. Another clinic that I work in is an amyloidosis clinic. This is a condition that I had never heard of myself, really until I started to get into cardiac genetics. Essentially, it is this protein from the gene called TTR that becomes misfolded and clumps up in different organs. Primarily can cause heart failure and neuropathy, but can also cause some kind of other unusual features such as carpal tunnel syndrome and gastrointestinal problems. It's a really under-recognized condition, definitely. So I kind of take every chance I get to spread awareness about it. And then finally, we see a lot of dyslipidemias. One example of that is something that's called familial hypercholesterolemia. Essentially, it's a problem that causes an increased amount of LDL cholesterol, which is the bad cholesterol in the blood. And exposure to these high levels of cholesterol over time can increase the risk for heart disease and other cardiovascular complications. It can depend on the severity if someone has one mutation or two mutations. And it is actually a condition that is pretty easily managed. These patients are encouraged to take statins, which is a medication that helps to lower the bad cholesterol in the blood, and then also to modify their lifestyle, proper diet and exercise to help decrease the risk of developing heart disease. Okay, so I won't, belabor this slide too much because I think we already kind of know the basic components of a genetic counseling visit, because it tends to be, fairly consistent between all the specialties. But something interesting that I've had come up in this setting is this question right here. Can you tell me what I've been diagnosed with? And I can't tell you how many times I have gotten this question, from patients who recently were diagnosed with, for example, a cardiomyopathy, and they just have no idea what they've been diagnosed with. They're very confused and they're very nervous about, the potential to, say, pass it down to their children. So a big portion of the visit is me often explaining to the patient what they have, and explaining kind of the basic genetics concepts of it, as well as the inheritance. And then, of course, we want to work out, what test is best. Should we order single gene? Should we order a panel? Should we order whole exome sequencing? That's a big part of the conversation. And then finally, insurance concerns, is something that's probably, an issue for anyone in any specialty of genetic counseling. Patients are often concerned about things like cost and, can these results be used against me? Will I have any privacy with my genetic results? So that's also something that we discuss with them. And then these are some concerns that are, kind of come up often in cardiac genetic counseling. They may happen in other specialties as well, but this is just, in the past 2 years here, what I've noticed can be concerning for patients. And one of these things is having a family history of sudden cardiac death, which is something that can potentially indicate that there is a gene causing arrhythmias in someone's family. So obviously, you can expect that there is a psychological impact for the patient's remaining relatives if their seemingly healthy family members suddenly died of an arrhythmia. So that's something that, I think a lot of my tough cases were these cases where there was a family history of just sudden death with no apparent precipitating factors. In addition to that, something that comes up a lot in cardiology is uncertain findings on genetic tests. People may be aware that sometimes when we get genetic tests back, the results aren't always clear-cut. Sometimes we aren't sure if the genetic change is actually causative of a disease. And this makes it, a little tricky to figure out how do we best screen the family for this condition? Are they at risk? And also, how do we communicate this uncertainty to the patient themselves so the patient doesn't feel overwhelmed? And then a type of testing that comes up occasionally in cardiovascular genetics is postmortem testing. Often in these cases of a family history of sudden death, they may pursue what's called a molecular autopsy, which is genetic testing on the deceased to help check and see if there's any potential mutations we can identify, and can kind of help us figure out why did this person pass away suddenly, and what is the risk to the remaining family members? Should the remaining family members consider something such as getting a defibrillator, for example, to protect them from any dangerous heart rhythms? So super quick, this is just kind of an example pedigree of a patient that I had seen, and it was interesting, not specifically because of the cardiac genetics of it, but kind of for some other factors. You can see all these yellow sections here indicate patients affected with a condition called HHT. Essentially, it causes abnormal blood vessel formations in the body and can cause problems with bleeding. However, these individuals here also had a dilated cardiomyopathy, and their deceased brother was thought to have heart failure. And in rare cases, HHT can cause basically a certain type of heart failure. But looking at all these cases of dilated cardiomyopathy and another relative on this side who is thought to have some type of heart issues, we were having a discussion about, is it possible that there are actually two different genetic conditions running in this family, or are these heart problems just related to the HHT and these patients are just happening to have some rare complications? So this was an interesting case, not even because of the genetics so much, but because of, this patient had already gone through all this counseling and testing for this other condition. And now we were coming in and talking to him about the potential of there being a second condition in the family. He had already known that his children didn't inherit the HHT from him, but now we had new concerns about, the potential of a dilated cardiomyopathy gene running through the family as well. So this was just kind of an interesting case, kind of, some interesting psychosocial aspects of this as well. Okay, and that's it. I think we're a little behind the times now. So maybe I will stop sharing and maybe won't take any questions at this time and come back for questions at the end. And of course, here's my email address. If anyone has any interest in cardiovascular genetics, please email me. I love answering prospective student questions.
Thanks, Sarah. Just quickly, we did get a question about shadowing, and we're not currently able to accommodate shadowing requests at this time. Is that right?
Yeah, so it depends if it's someone already in a program or if it's someone who is not in a program at this point. It is a little bit more difficult just because of the regulations between like the hospital and the university. But if someone has specific questions about wanting, information about potentially shadowing here, I would encourage them to reach out to me, just because there may be some more specific information that I could give.
Okay, perfect. Thank you. So I am going to try to share my screen again. Give me 1 second. I'm going to share screen. And this is going to be for our pediatric / general genetics clinic. Emily Qian, who spoke to us last year, wasn't able to be here today, but she wanted me to share her talk for her. So let's get that going. Please let me know if you can't see and or hear it, but here we go.
Hi everyone, my name is Emily and I'm a genetic counselor here at Yale working under the General Genetics Clinic. I'm here to talk today a little bit about pediatric and general genetics. So to start off with, I'll go over a brief biography. So I actually graduated from UConn, so the University of Connecticut, and I studied psychology and molecular and cell biology there. Afterwards, I went to the University of California, Irvine, where I did my master's in genetic counseling. And the first job I took out of grad school was at Veritas. It was a genetic testing startup company that was performing whole genome sequencing intended for healthy individuals who wanted to just learn about their disease risk. And then from there, after about 3.5 years at Veritas, I since then been here at Yale working in the general genetics clinic for the past 2.5 years or so. So what exactly is general genetics? Well, it can be split into pediatrics and adult genetics, and that's mainly based on depending if the hospital you work at has a separate children's hospital or not. If it does, then you might be only seeing pediatric patients. Here at Yale, we don't have a separate children's hospital. It's all just under Yale New Haven. So that's why our clinic is called general genetics, which you might sometimes see interchangeably with adult genetics clinics. But the key piece about our clinic is that we don't specialize in a specific disease group or specific type of disease or indication. We really just see everything under the sun. So that includes cancer, cardio, and anything else that you might hear about today. So some of the common reasons for someone who might need to see general genetics are listed here. Mainly people are referred to us when they're trying to better understand if there's a genetic reason or genetic etiology for why they're experiencing their symptoms, or some kind of diagnosis that might tie multiple symptoms together, but their other physicians haven't been able to figure out. A lot of times you might hear about medical mysteries or diagnostic odysseys. That's often found in the general genetics clinic. We are trying to solve a lot of these cases. Some of my patients are over 40 years old and they have significant symptoms that they've just lived their entire life with, and doctors haven't been able to figure out before they finally come to the genetics clinic. And we're able to possibly give them a diagnosis in some cases. So I've listed some of these common indications here. So we see a lot of kids who have developmental delay or intellectual disabilities or autism spectrum disorder. We also see adults with these indications as well. We see people who have skeletal dysplasias, which means a problem with the bones. Sometimes they can be very fragile. Sometimes they can be too hard. And sometimes individuals can be short, or they might have disproportionate bones or other types of problems with their bones. We also see people who are born with what we call Brca defects. So it can be a problem with their heart or a cleft lip or palate, or they can have extra fingers or toes or fused fingers and toes. Brca defects just refers to anything that someone may be born with. In addition to people who have seizures, they might be referred to us to see if there's a genetic cause for the seizures. And if so, sometimes there's a better treatment option for them. We also see individuals with what we call metabolic conditions. So those conditions are typically found on newborn screening, where a baby has a heel prick and they're tested for these disorders. There are other metabolic conditions that aren't necessarily covered in newborn screening. But essentially, these are the types of conditions that sometimes can be treated with a diet adjustment and special formula added to their, and that's kind of how we treat some of those conditions. We also see patients who have muscular weakness or atrophy, in addition to connective tissue disorders, so people who might have very stretchy skin, in addition to family history of strokes or aneurysms, for example. So you can see that we see a lot of complex conditions that might affect multiple systems. And I listed one example here. So one condition called Stickler Syndrome, patients can have hearing loss, they can have a cleft palate, which means the palate, the top part of the mouth inside didn't close completely when forming, mitral valve prolapse, which is a problem with the heart, vision loss due to retinal detachment. So the retina is the back layer of the eye that takes in the light and sends those signals to the brain to process. So if your retinal tissue detaches, then it can definitely result in vision loss. And sometimes it can be reattached with surgery. And then these individuals can also have bone and joint problems. Even within the same family, some people might have one symptom, some people might not have any symptoms of Stickler syndrome, or they're very mild and hard to pick up. So it can present very differently, but if we do diagnose someone with Stickler syndrome, we want to check all of those different organ systems and make sure they're working okay, and check them over time to make sure they don't develop hearing loss later, or develop the vision loss due to the retinal detachment later. So usually after we find a diagnosis for someone, we have to coordinate their care. That includes helping testing any other relatives or providing recommendations for the condition. In some rare cases, we actually might be able to direct them to a curative treatment, whether it be an enzyme replacement therapy or some kind of gene therapy that might be available. So that's not common, but it's becoming more studied, and more medications are starting to come out. So definitely a hot area right now. The team members that you'll probably be working with overall include administrative staff. You may be, if you're lucky, you might have a genetic counseling assistant as well, or a nurse coordinator. Those individuals can have additional training in medicine, so they might be able to disclose negative results, or may be able to determine whether additional records are needed for a visit before the patient comes to see us, or gather family history information beforehand as well. You may work with a social worker who provides that additional psychosocial support, or identifies resources for families that might not necessarily be specific to genetics. The genetic counselor is probably a little bit better suited to searching for what kind of advocacy groups are appropriate based on a diagnosis. But in terms of daily types of difficulties that families might be going through, for example, if they're looking for disability services, a social worker might be better well equipped to identify those for the families. Metabolic dietitian, if you see metabolic patients, they're registered dietitians who have specialized training for these taking care of these patients. You may work with nurse practitioners or PAs, physician assistants. So these are advanced practice providers that typically have some additional genetics training, usually on-the-job training. So after some time, they may specialize in a certain type of disorder. It just depends where you work. And then there's also the medical geneticist, which is a key part of the general genetics team. So that is a physician who will be seeing the patients. And they typically have already done a residency in pediatric or internal medicine. And then they do an additional residency in genetics. You might hear it called a fellowship or residency. Basically mean the same thing. So what's the role of a genetic counselor during these visits then? We help to elicit the patient's concerns. Excuse me. Excuse me. We also gather their medical and family history if it hasn't already been done. If it has already been done, we'll probably go over it again and make sure there's nothing else that we're missing. A physical exam that's usually done by that advanced practice provider or medical geneticist. We also review the benefits, risks, and limitations of genetic testing. We go over the different types of results that are possible. And then when the results do come back, we help to interpret and return those results to the family in a digestible manner. Then afterwards, we'll help provide continued support and identify any other resources for the patient and their family that they might need. Something that I didn't necessarily list on here, but is a part of the job as well, is that if we're doing genetic testing, oftentimes the genetic counselor is the person who helps fill out the medical part of the paperwork that has to be done. Because we have to talk about the symptoms and why this individual needs genetic testing. So I wanted to go over one case example here of what I may or may not see in the genetics clinic. So for example, let's say a 9-month-old male is coming in to see me and they were born with a congenital heart problem called pulmonary valve stenosis. So it's a very specific type of heart defect that someone can be born with, and it's pretty rare. And the baby was born with normal weight and size, but then over time, the pediatrician noticed that the weight gain started slowing down, as well as the growth in general. So at 9 months old, that's pretty concerning. We see a lot of babies who are starting to fall off the growth curve. So this is a pretty common reason to refer to us. And then together with both of the above symptoms, the parents, after talking to them some more and going over the different systems, parents have also explained to you that they feel like the baby has pretty easy bruising. Maybe they had a blood draw before and they noticed bruising just from, the nurse trying to take the blood, for example, or maybe they had prolonged bleeding after a cut or something. So putting those three together, when you're doing a family history, you start asking a little bit more about conditions that you might be thinking about on your differential list, so the different possible diagnoses. So going over the family history, you find out pretty much not too much going on. The only thing is, let's say mom is shorter than expected. And she also had some kind of unknown heart problem when she was a baby. She doesn't know what it was, but she was otherwise healthy and didn't need surgery. So putting all this together, oftentimes families will ask you, or the geneticist, what do you think my kid has? And maybe 20 years ago or 30 years ago, when we only knew about a handful of conditions, it might have been easier back then. But now we know about, over 7,000 different conditions. In addition to that, we now understand that a lot of individuals can present very mildly. We expanded the spectrum of symptoms that someone can have and the spectrum of severity that we can see. So now when people ask us, what condition do you think my child has or that I have, oftentimes we just, I would say I've never heard myself or the geneticist say to the family that we are certain that the child has any condition in particular. Because of the expansion of this knowledge, we can't really pinpoint anything. But sometimes what we will say is, based on what I'm seeing here, the multiple symptoms, I do think it is genetic. I just don't know what exactly it is, and we need to do testing for that. So fast forward, let's say we do testing for this individual, and we find out that they have Noonan syndrome. So that's a condition that kids can be born with what we call pulmonary valve stenosis again, and it's something we often see together and think of immediately when we see that a baby born with that, especially when they start to slow down with their weight gain later on. And they can also have, problems with the platelets, and which leads to the easy bruising or prolonged bleeding times. And they can also have some other symptoms. Sometimes there can be some mild hearing loss as well. Some developmental delays depending on the type of Noonan syndrome. So you can see that even if I said Noonan syndrome, it really depends on which gene. So all of that happens after the visit. I would go over the results with the family. Let's say it's a dominant form of Noonan syndrome here, or autosomal dominance, and we go over that inheritance pattern, go over who else might need to be tested or might want to consider testing. So in this case example, it's the mother. These individuals can also be of short stature. So for the baby, we might consider sending to endocrinology to monitor and also see if maybe growth hormone is something that might be given at some point in the future. For the mom, we're more concerned about adult onset symptoms of Noonan syndrome. So for example, they can have something called Hypertrophic Cardiomyopathy, which is a thickening of the heart muscle, makes it harder for it to pump. So that's definitely something that we want to keep an eye out for. And then mom might just want to know her future risks to other children that she might be having down the line. So we'd go over all of that with the family. And again, we help to coordinate care between any other specialists that the baby might need to be followed with. And then we provide that psychosocial support and resources, especially when given the new diagnosis that someone might not be expecting. I will say, as part of my role as a general genetic counselor, we also get called to the hospital sometimes. So when we're on call, that means that anyone on the floor or the ICU, the intensive care units, may call us for a genetic consult. So for example, if you have a patient that's hospitalized with the symptoms that we just mentioned, maybe the baby is severely, in addition to not really gaining a lot of weight, maybe they have seizures and they're coming in and they think that it might be genetic. They'll page us, and then we'll have to go see and evaluate and do talk to the family about whether or not testing is indicated and where to go from there. So in addition to just seeing patients in outpatient setting, sometimes we see patients in inpatient as well. So I just wanted to end with some of the common conditions that you may see in a general genetics clinic. So you may have heard of Down syndrome, neurofibromatosis type 1, 22q11.2 deletion syndrome, which is a microdeletion syndrome that's pretty common. Prader-Willi, we already talked about Noonan, PKU or phenylketonuria. It's one of those metabolic conditions that I briefly mentioned before. Cystic fibrosis, and then Duchenne or Becker muscular dystrophy is another common indication or common condition that you may see. I will say though, a lot of hospitals have specialized clinics for these common diseases. So in those cases, you may not end up seeing those patients in the general genetics clinic. You may see the more complex cases or these medical mysteries versus the ones that are more easily diagnosed or taken care of by other providers. So that's kind of, I think, interesting that these are some of the more common conditions, I would say 10, 20 years ago that you might have seen. Nowadays, I almost rarely see some of these conditions because they're followed in other specialty clinics instead, as other physicians become more well-versed with how to order simple genetic testing rather than these medical mystery cases where it's best referred to a general genetics clinic. All right, so other than that, that's pretty much all I have for you guys today. I'm sorry I couldn't be there in person, but hopefully this was helpful and gave everyone a taste of what pediatric or general genetics may look like. Thanks again, and bye.
Okay, so that was Emily with general and pediatric genetics. I'm going to, let's see, Amy, I think you're next before our break. Hang in there, everybody. 10 minutes for coffee to come, but last but certainly not least, we'll have Amy here.
Okay, good afternoon, everyone. Hope that your day's been going well. I'm going to share my screen. So today I am pleased to talk to you about cancer genetic counseling. My name is Amy Killie. I'm a genetic counselor at Smilo Cancer Genetics. I work closely with Alex. And just some background about me. I graduated from State University of New York, so SUNY Oswego, in 2014 with my Bachelor's of Science in Zoology. I then took 1 year off between graduating and going to my master's because I wanted time to apply for programs, also wanted to get some volunteering experience. I graduated from the Icahn School of Medicine at Mount Sinai with my master's in genetic counseling in 2017, and I'm board certified as of 2017 and actually just recertified this year because as a genetic counselor, you need to recertify every 5 years. And I've been with the Smilo Cancer Genetics program since June of 2017, so coming up on my 5-year anniversary here, where I practice specifically clinical cancer genetic counseling. So just as an overview about hereditary cancer in general, we like to refer to red flags for hereditary cancer. That just means that there's specific findings in someone's family that may be more suspicious that the cancers could be hereditary. That would be the big thing, cancers at early ages. And that's not all cancers. Some cancers may naturally occur at younger ages, but for example, breast cancer diagnosed under 50, particularly under 45, that is in and of itself suspicious of a hereditary predisposition to develop that type of cancer. Another thing that we may see is multiple family members in the same family with the same type of cancer or associated cancers. So that would be multiple people in multiple generations on one side of the family, all with colon cancer, for example. Or there are some cancers, when they are hereditary, they can be associated with other risks of other cancers, such as breast or ovarian cancer or pancreatic cancer in the same family, or seeing colon and uterine cancer in the same family. So it's not necessarily seeing more cancer in general, though sometimes that can be a risk factor, but particularly if it's the same type of cancer or known associated cancers, that would be a red flag. Rare cancers. Some cancers are very rare and may not be hereditary, but there are specific cancers that are rare that are more likely to be hereditary. That includes ovarian cancer, pancreatic cancer, or male breast cancer. Those cancers specifically are more likely to be hereditary. Other cancers, such as these tumors with very long names, paragangliomas and pheochromocytomas, are rare tumors. Paragangliomas are typically benign. They occur along this axis of the body, but they are very rare tumors that actually have a high percentage, a high likelihood of being hereditary. A pheochromocytoma is essentially a paraganglioma that sits on the adrenal gland, so right above the kidney, and people with a pheochromocytoma, since it's on the kidney, may develop symptoms of essentially overactive fight or flight symptoms such as anxiety, sweating, flushing, etc. So those tumors, specifically rare tumors, are also known to be more likely to be hereditary. Cancers that are unusually aggressive. So those cancers could be things like prostate cancer. Prostate cancer is very common in the general population for men. However, it's less common for prostate cancer to be aggressive or be a cause of a man's death. So when we see prostate cancer that is aggressive or spread to other parts of the body, that is also a red flag for that cancer being hereditary. Or one person having multiple types of cancer. Cancer is common in the general population. 1 in 3 people will develop cancer. However, seeing one person with multiple cancers does increase suspicion that that person may have a genetic predisposition to develop more than one type of cancer. So that includes women or men who have bilateral breast cancer, so cancer in both breasts, or someone who've had colon and uterine cancer. Additionally, we also know that individuals who are Ashkenazi Jewish are more likely to specifically have hereditary breast and ovarian cancer, which I will talk about in a little bit, but there are 2 genes, specifically BRCA1 and BRCA2, that anyone of any ethnicity or ancestry can have mutations in. However, individuals who are Ashkenazi Jewish have a higher likelihood of having mutations in these 2 genes. Specifically, 1 in 40 people that are Ashkenazi Jewish will have a BRCA1 or BRCA2 mutation, compared to the non-Ashkenazi population, which is about 1 in 400. Now for a quick poll. So I mentioned cancer is very common, but approximately what percentage of cancers are hereditary? Is it less than 5%? Is it between 5 to 10%? And again, I'm talking average here. Is it between 20 to 25%, or is it around 40%? So take a couple seconds, think approximately what percentage of cancers are hereditary.
All right.
Wow, 46%. Great, guys. That's basically all. You guys can all be cancer genetic counselors now. So that's correct. So about 5 to 10% on average of cancers are hereditary, which a lot of patients are surprised by. I think it's almost this idea that most cancer is hereditary, but 5 to 10%, definitely not a small amount, but the grand majority are actually not hereditary. And there's a nice little pie chart here. So what causes cancer? 70% of cancer we consider to be sporadic, meaning that it's due to things like the environment, like asbestos exposure, radiation exposure, things like lifestyle. We know that tobacco use can be a risk factor for certain types of cancers, including lung cancer. The natural aging process is also a risk factor for cancer. That's why we tend to see cancers diagnosed in older ages, because as we age, we have a higher likelihood of acquiring a random mutation that could then develop into a cancer. Also, sometimes cancer does just occur due to complete random chance. You see hereditary and familial, and those terms do sound very similar. We distinguish them in cancer genetics a little bit. 20% of cancer is familial. Familial means you may see clusters of the same type of cancer in someone's family. However, we do not find one single genetic change, one single gene mutation that is causing those cancers. So we do think that for familial cancer, there may be small genetic factors, possibly in multiple genes, possibly polygenic, that is working with shared environmental factors and lifestyle factors, because families often live in the same locations, have similar lifestyles, and this combination may create an overall higher risk of cancer in that one family that's not caused by one single gene. Hereditary is a type of cancer that we can do genetic testing for. That means someone is born with or they inherit one single genetic change, a harmful gene mutation or pathogenic variant that predisposes them over their lifetime to developing certain types of cancers. And this is an overview of what we think about, why cancer develops. This is an oversimplification, but I think it kind of drives the point home of why there is this predisposition. So on the top, these are cells in the body. So everyone, as we know, has 2 copies of every gene. So with sporadic cancer at the top, over time, a gene could acquire a mutation, again, due to some sporadic factors, such as the environment, lifestyle, aging, random chance. However, that second copy of the gene is still working, so that cell continues to grow and act normally. It's only when someone acquires a second hit, the gene requires a second hit, that cell essentially may be non-functional, and through other complicated processes can then go on to become a tumor where that cell growth is now not regulated. With an inherited mutation, it's different because someone's already born with a mutation already in one copy of their genes, and this is present in all the cells of their body. However, they have one copy of their genes still working normally. So essentially, that one copy can work throughout someone's entire lifetime, but since someone's essentially down a line of defense, if someone needs to acquire only a single mutation in that one copy of the gene to then start the process potentially of a tumor developing. So that is why with hereditary cancers, we may just see more cancer in the family, younger cancers, more rare cancers, multiple cancers in one person, things like that. And this is called, this process is called Knudson's 2-hit hypothesis of why cancer develops and why specifically we see hereditary cancer act the way or present the way it does in certain families. So just want to talk about a typical day for a cancer genetic counselor. And I'd like to start by talking about an example case. So I know we've talked, my other colleagues have talked about genetic counseling in general, so I won't go into the details of exactly the genetic counseling process, but essentially the patients that I see are those who have cancer, who have had cancer, or who have family history of cancer. And the goal through a pedigree is to look for those red flags that I mentioned earlier to determine what is the likelihood or the risk that there is a hereditary predisposition to cancer in someone's family. So for this case, this is a 63-year-old female. She was diagnosed with breast cancer when she was 56. She never had genetic testing previously, but she came in now to talk about genetic testing. In her family, you can see a lot of cancer going on, all those little dark corners. On her maternal side of the family, there is a mutation in a specific gene called ATM. So her cousin had breast cancer and has reportedly an ATM mutation, which I could not confirm with records. And ATM, which I will talk about in a little bit, is a moderate risk breast cancer gene. So the ATM mutation may be playing a role in her cousin's breast cancer, and that is a hereditary cancer gene. However, it appeared, based on what my patient reported, that that ATM mutation was coming from her cousin's father, which is not a blood relative to my patient, meaning that my patient would not have been at risk of inheriting that that same mutation. So thinking about red flags in her family, what we're also seeing is, apart from her history of breast cancer, which is not a very young age, it's over 50, it was after menopause, which is less likely to be hereditary. We do see an ovarian cancer in her maternal great aunt, but a little bit distant to her and related through her mother, who is 83 with no cancer. On her father's side, however, her paternal uncle did die from prostate cancer. And if you remember, though prostate cancer is common in men, 1 in 9 men will develop prostate cancer. Metastatic prostate cancer is less common and more likely to be hereditary. And also thinking about a pedigree, I think about limitations in family histories. Her father's side is small with only men, which can limit an assessment. So I like this case because it shows kind of the importance of taking into account both sides of the family, thinking about those associated cancers, thinking about what can we confirm with records. Ideally, we always want to confirm test results with records, but sometimes we can't. So this is a great case to show that even though there's risk factors on maybe her mom's side, there's also maybe more significant risk factors on her father's side. So for her, we talked about hereditary cancer, specifically BRCA1 and BRCA2, which I will talk about, and talked about other hereditary cancer genes as well. Nowadays, with cancer genetic counseling, of course, we go through the benefits of doing genetic testing, which for cancer genetic counselors is really prevention, particularly for individuals who maybe do not have cancer or who possibly could have a predisposition to another cancer. The goal of knowing about hereditary cancer risk is that if we know someone's at higher risk of certain cancers, there's certain screening options that possibly be done, and also possible surgical options that can actually prevent cancer. Additionally, for people who have cancer, it can be important for treatment decisions, meaning that there are some chemotherapies or treatments that may be more targeted for individuals with certain gene mutations, and it also may be helpful in planning surgery. So for her, we did genetic testing, and nowadays genetic testing tends to be comprehensive. I know there's a lot of genes listed here. About 12 years ago, 13 years ago, 11 years ago, 10 years ago, we were really only doing testing for 2 genes when we're talking about hereditary breast cancer. So BRCA1 and BRCA2, colloquially called the BRCA genes. A lot of people have heard about these genes since Angelina Jolie went public with her own BRCA1 mutation and her decision to have a prophylactic bilateral mastectomy to remove both breasts. Additionally, these 2 genes, we've been testing for them for over 20 years. So we have a lot of information, and they were the only genes we were testing for quite some time. So a lot of people refer to these 2 genes as the breast cancer gene. However, there are a number of other genes related to hereditary breast cancer, including one syndrome called Li-Fraumeni syndrome related to mutations in TP53, which is more rare. Li-Fraumeni syndrome, you would expect to see cancers in childhood, including leukemias in childhood, brain tumors, osteosarcomas, cancers of the bone, sarcomas, cancers of the soft tissue, and a risk of breast cancer usually before the age of 35. So it is a very significant hereditary cancer syndrome. Cowden syndrome is another hereditary breast cancer syndrome related to a high risk of breast cancer. Individuals also can develop rare polyps of the colon, uterine cancer, kidney cancer. Additionally, they have on average a larger head size and may have specific findings on the skin called trichomoniasis. So another rare hereditary cancer, breast cancer syndrome. Another one is called CDH1, hereditary diffuse gastric cancer syndrome, where specifically individuals are at risk to develop lobular type breast cancer, a type of breast cancer, and a rare stomach cancer called diffuse gastric cancer, which is a type of gastric cancer that's very hard to screen for. So for individuals with mutations in these genes, in CDH1, there actually is a recommendation for a prophylactic gastrectomy to remove the stomach to be preventative against the high risk of gastric cancer, which is oftentimes not able to be screened for. Another syndrome is called Peutz-Jeghers syndrome, caused by mutations STK11. You can also see a risk of breast cancer with this syndrome. However, what you can also see is they're at risk to develop polyps of the small bowel, and they may develop something called intussusception, where the small bowel collapses on itself. They also have oftentimes distinctive lip markings, almost like, I've been told, almost like someone ate like a bunch of Oreos, kind of like dark freckling on the lips or on the fingers, and risk of other cancers as well. Another rare syndrome. There are also other genes that are more of a moderate risk and are actually more common that we're finding a lot more often now that we're doing more comprehensive genetic testing. I mentioned ATM, but there's another one called PALB2 and CHEK2. So those are the mainly hereditary breast cancer genes. Hereditary colon cancer, the most common one that we talk about is Lynch syndrome, which is mainly characterized by increased risks of colon cancer and endometrial cancer, though we may see risks of other cancers as well, such as stomach cancer, ovarian cancer, pancreatic or bile duct cancer. There's even other genes related to risk of ovarian cancer specifically that are more in a moderate risk, called RAD51C, RAD51D, and BRCA1. And there's a lot more. So testing nowadays, how we lead with testing, at least in our program and other programs as well, is we tend to do more comprehensive testing because there are a lot more genes out there that we know of, and their cancer risk is really dependent on the gene. So doing bigger testing now is a benefit because our technology has gone cheaper, faster, and better, and we can rule out multiple predispositions at the same exact time, while about 10 years ago, we were limited to just testing for BRCA1 and BRCA2. So my patient did have a comprehensive panel testing, and she had a BRCA1 mutation, which was actually, it was a little bit surprising because, as we talked about, the only significant risk factor in her family, apart from her history of breast cancer, was her paternal uncle's metastatic prostate cancer. What's interesting with BRCA1 is there is a slightly increased risk for men to develop prostate cancer that tends to be more aggressive. So it's based on the family history, it was most likely that she inherited this from her father's side of the family. And you can see there's also, I know these have been talked about by my other colleagues, but there was a variant of uncertain significance, which are very common nowadays in cancer genetics when we do these bigger panels. And especially with bigger tests nowadays, we do find uncertain results about 20 to 30% of the time with these panels. And most of the time in cancer genetics, uncertain results, variants of uncertain significance or VUSs, end up being reclassified to benign. So they are not actionable or things that we act on. And the laboratory in the future, usually takes even a few years, will update us to either upgrade the result to a positive, which is less likely, or downgrade it to a negative result. Oh, and that's the mutation. For my patient, she was surprised in a way, and I was a little bit surprised as well. And she was someone who really struggled a little bit with these results because she was concerned about her risk of a second breast cancer. And is that something that she should have a prophylactic mastectomy for to be preventative at her age? You know, she's not very young, but she's definitely not older. She has many years to live. So it was kind of thinking about how should I go about dealing with this risk? She still had her ovaries, so it was something that she had to think about in terms of removal of the ovaries, which is recommended for women who are BRCA1 or BRCA2 positive, because our screening for ovarian cancer is not as effective as our screening for breast cancer. And so the goal, as I mentioned, of doing this type of testing is prevention and increased screening when possible. So further follow-up that I did with this patient, but also with other cases in general, again, if we're talking about my typical day, that I discuss results with the patient. And then based on the results, I would refer to any appropriate providers for management, such as a gynecologic oncologist for my patient, to discuss removal of the ovaries and discuss the limitations of ovarian cancer screening, referral to a high-risk breast oncologist to talk about screening for breast cancer, the risks and benefits of doing a bilateral mastectomy to remove both breasts in terms of prevention, And in terms of other types of results, I would refer to other specialists familiar with the syndrome who can also provide guidance in terms of cancer screening. And of course, for this patient and other patients, I provide resources for themselves and family members, including a letter for relatives, something they can share with their family, describing the results and recommendations for testing. Also, there's a lot of resources online in terms of support groups, information, and directing patients to those support groups, and possibly even referral to a psychiatrist to talk to just for more psychosocial counseling in dealing with finding out someone has a mutation. Every patient takes results a little bit differently. For some, it can be very difficult to hear this news, but they find it important. For other people, it's almost a relief to have an answer and a plan going forward. So I would say to patients, no matter what the results are, it's information, and especially for hereditary cancer, it can be very, very powerful for themselves and the information they can provide to relatives. A lot of what genetic counselors do is document in the medical record, which is very important. So other providers know what was discussed. They can go back to my notes, see the cancer risks I mentioned, see screening recommendations, and any patient's questions that I answered at that time. Of course, I notified the referring provider of the results. So making sure the whole team's aware of what the results are so the patient is fully plugged in. The results are scanned in the medical record. Again, this is really just making sure that these results are clear, that they're easily accessible, that they're part of the patient's medical record, and that the medical team is aware. Writing a summary letter, which summarizes the results in detail, because the report is really not clear sometimes to patients who may not have the medical terminology. So the letter is really helpful in providing those cancer risks, recommendations, what we talked about, what that means for relatives in detail, so they can also share that with other providers or with their relatives. For our program here, we present cases at Case Conference, which is great. It's essentially our team meeting once a week. We present positive results or difficult cases, and we get the team's input if there's anything additional that they should be tested for, should be screened for, and it's nice to have that group consensus. And throughout the rest of the day, I'm doing other clinical and program tasks. One of my other roles here at the program is actually triaging incoming referrals to be scheduled. So I look at every incoming referral, determine the indication, and determine how they should be scheduled, and following up with providers, looking at past test results to see if any testing is indicated, which I enjoy because it's another way to use my clinical brain, and also helps the admin team in terms of their own scheduling process. So overall, cancer genetic counseling, it's something that I'm very passionate about. I think it's very important. It is information that can really change lives, change outcomes for patients, provide information in terms of cancer risk. Some days can be difficult in disclosing some information, talking with patients, but overall, I find it very rewarding to provide that information. I will answer questions now and also at the end, but if there are any questions you have specifically about being a cancer genetic counselor or my background or any more of my day-to-day tasks, please email me.
Thanks, Amy. That was a really great talk. I'm just going to share my screen because I started the countdown until we come back for the second half of our session a little earlier, just to get us back on track. But if you don't mind, I think there was a question, Claire, did you happen to see, regarding insurance and genetic testing?
Yeah, so there was one question, Amy, about whether there are any barriers that the patient or the genetic counselor might experience when it comes to getting genetic testing covered through insurance.
Great question. So insurance is probably the bane of every genetic counselor's existence. I will say, from what I've heard from my other colleagues and other specialties, cancer genetic testing is more easily covered than other specialties, but we can still run into barriers. So insurance has specific guidelines mainly based kind of off the red flags I talked about, meaning that if a patient does not have this family history or this personal history, they will not cover testing. Most insurance companies align with national guidelines for recommendations, which can make it very easy. However, some insurance companies make up their own guidelines, meaning that someone could technically meet national guidelines for recommendations, but they will not meet their insurance guidelines. So sometimes the specific insurance is a barrier. Another barrier is that even though I would say we're past the era of testing for just BRCA1 and BRCA2, a lot of insurance companies aren't in that era yet. They're kind of living in the past. They will only want to cover testing for BRCA1 and BRCA2, which to us, based on a person's family history, if his family history is concerning for hereditary breast cancer, specifically doing just BRCA1 and 2 testing is not sufficient. So sometimes it can be difficult when we want to do a more expanded panel, a panel meaning, again, looking at multiple types of genes in one test. Some insurance companies do not want to cover a larger panel, even though to us, we feel it's clinically indicated. So that can sometimes be a barrier in terms of getting that covered. And every insurance policy is a little bit different. What I will say for cancer genetic testing is that the cost has gone down, and there are some laboratories out there that will actually do even a full panel, a full comprehensive cancer panel for an out-of-pocket cost of $250, which is not a small amount of money. However, compared to how the cost was even 7 years ago, it has gone down, which is good because there are some patients who testing for them is indicated, but their insurance will not cover either panel testing or will not cover testing at all because of certain requirements, but they are able to get the testing they need for an out-of-pocket cost that may be reasonable to them.
All right, it looks like that was all of the questions for right now, but I'm sure Amy would be happy to answer more if there are some later.
In just about a minute until we start the second half of our day today.
Alex, do you want me to pull my slides up?
Yeah, why don't we do that?
Okay. Since I have 400 things open.
That was a good sign.
Yeah, I guess. Except, hold on one second. Let me try this again. Nope. Sorry. My daughter was helping me do this last night and something got screwed up.
That's all right. You have some time.
Excellent. Okay. So. Okay, so hopefully you can see my slides, yeah?
Looks good.
And hopefully only my slides and not my notes.
I believe so.
Okay, good. Okay, yep. And I'm good to go whenever you want me to start.
Okay, I think go on ahead. I appreciate it.
Okay, so hi everyone. I'm Janice Berliner. I'm the director of the Master of Science in Genetic Counseling training program at Bay Path University, which is in Western Massachusetts. And I thought before I tell you the things that you probably want to know about what to expect in graduate school, I'd give you a 30-second bio of who I am and how I got here. So I've been the program director at Bay Path for 4 years. Before which I was a clinical genetic counselor for 29 years, 9.5 of which was in prenatal genetics with a little bit of pediatrics thrown in. And then for 20 years, I worked in cancer centers, seeing patients for cancer risk assessment and genetic testing, much like you just heard about. Over those years, our field has changed a lot and grown a lot, and I learned a lot along the way, as I'm sure you will when you begin your journey to become a genetic counselor. I had always wanted to be a program director, and 4 years ago, I finally made it work for myself. So I thought we would talk about some of the basics of what to expect in a graduate program in genetic counseling. As you may know, there is an accreditation organization called the Accreditation Council for Genetic Counseling, or ACGC. This organization was formed to accredit genetic counseling training programs, and it sets standards for all programs that they need to follow in order to be accredited. At the beginning, and then subsequently throughout the years, they need to be re-accredited. So they need to continue to prove over and over that they're meeting the requirements. Naturally, when you're applying to programs, you're going to want to be sure that the programs you're looking at are accredited by ACGC, and it will say that on their website. So if it doesn't say it on the website, you know to be a little bit cautious of that. I think it's pretty unusual for you to find anything like that because, you know, we all know what genetic counseling training programs are out there, and if there's something that's not accredited, it's not going to stick around. But due to these accreditation standards, all programs must provide certain things and make sure that their students graduate with specific competencies. The 3 legs of the stool, so to speak, for all programs include coursework, fieldwork, and research in the form of a thesis or a capstone project. So let's start with the coursework. I realize that BayPath is not necessarily the same as every other program, and I can only speak to how we do things, but I'd be really surprised if they aren't all very similar in this regard. The main difference between our program and most others is the fact that ours is online, which means our lectures are mostly pre-recorded and not presented synchronously with everyone in class together. Some of them are, but it's not the norm. And as I mentioned, each program must be accredited by ACGC, which means that there are rules we must all follow and core competencies we must make sure that our students achieve. So every program will provide for you medical genetics courses, reproductive and cancer genetics courses in one form or another, research courses that lead you through the process of writing a thesis or capstone project, and of course, clinical coursework that goes along with your fieldwork rotations that will prepare you for and allow you to process and present cases to your supervisors and classmates and become increasingly capable of seeing patients on your own. All of this is typically done within a framework of medical ethics, equity, diversity, inclusion, justice, and belonging. In each course, I would expect that you would have a lecture accompanied by readings or videos and an assignment. Some assignments will involve role plays, standardized patients, or other ways to interact with your classmates, genetic counselors, and other healthcare professionals to learn the skills you need to counsel appropriately and effectively. Other assignments may help you learn how to write a patient chart note or a summary letter or research a specific disease to present to a patient or create educational materials for patients or healthcare professionals. Of course, you'll also be tested on your knowledge, and many programs will use test questions in the style of the board certification exam to get you used to the format and the pacing needed to pass the exam. Second, there's your clinical work. Again, every program works differently, although there are core fundamentals that you must have. In general, you'll start out observing a genetic counselor or several of them. You will likely be asked not to say anything during the session since your skills are not developed yet, but you will have the opportunity to learn not only the scientific material, but the nuances that the genetic counselors use in assessing the patient's knowledge, interest, and receptivity to the information. We find that not every patient is willing to hear that much, and some are in a fragile emotional state if, say, they or their child or fetus was recently diagnosed with a serious condition. So determining our patient's medical literacy and ability to handle the information we're presenting may be the most important aspect of our jobs as GCs, and that's one of the fundamental things you'll begin to learn in your observations. And they may ask you to draw a shadow pedigree while they're doing their cases to see how your pedigree compares with theirs, and that helps in your learning too. And then, of course, as time goes by, you take on increasingly greater responsibility in cases until the final semester of your training, when you'd likely perform the whole session by yourself with supervision. In terms of content, every student must have what we call the big 3 rotations in prenatal, pediatrics, and cancer. In a prenatal setting, you'll see patients who are pregnant or would like to be and have concerns about their ability to have healthy children. This may be related to things like maternal age, exposures to toxic substances, family histories of genetic conditions, abnormalities identified on ultrasound, or even a blood relationship between the patient and her partner. In a pediatric setting, you'll see children who have features that may be consistent with a genetic condition and need to be diagnosed if that's possible. Or you may see children who were diagnosed previously but are coming back for periodic follow-up. You may even see newborns in the neonatal ICU who are suspected to have a condition that needs to be diagnosed so that treatment or surgery can be initiated. In a cancer setting, which you just heard all about, you now know that you'll see patients who have a personal and or family history of cancer who are hoping to find out if there's a hereditary component. That information, of course, can both guide treatment options and provide risk assessment for family members. It could even inform the patient if there are increased risks for more cancers than they've already had. Some programs, like ours, will not have you doing any rotations in your first semester so that you can get used to graduate school and knock out more of the academics in the beginning. We start in the second semester, while some don't start until the summer. But in any program, these 3 clinic types are required to collect the cases you need to be eligible to sit for the board certification exam. But there are many other types of settings that you may have opportunities to rotate through, like cardiogenetics clinics or ophthalmology or neurology or psychiatry. You may even wish to do a rotation in a laboratory or other industry type setting, or a public health department or newborn screening lab. The sky's the limit, really, if you have the time and if your program allows it. So again, when you're researching programs, think about what might be important to you and ask the questions that will help you figure out what it is that you want to do and where would be the best place for you to do it. The third leg of the stool is your research project. And because I've always wondered this and thought you might too, I looked up the difference between a capstone project and a thesis. A capstone project attempts to address an issue in the field by applying existing knowledge towards a real life problem, whereas a thesis seeks to create new knowledge through student research, trying to prove or argue a hypothesis rather than just investigate a topic. So each program has a research component that is required, but which type of component varies, and of course is something else you may wish to research ahead of time. Most programs, I believe, are like ours, with a research course first that helps you understand the process, the difference between qualitative and quantitative research, and how to write a proposal. Then there are the capstone courses, during which you apply for institutional review board approval and do the data collection and write-up. Most programs will encourage you, though they may not require you, to present your research on campus and or submit it for presentation or publication to a professional organization, such as the National Society of Genetic Counselors, the American Society of Human Genetics, American College of Medical Genetics, American Society of Clinical Oncology, or American College of Obstetrics and Gynecology. I could go on all day. But it's a really good opportunity to show the research that you've done and to kind of show the world what kinds of research your program allows. So those are the required components, but most programs, if not all of them, also have supplemental activities that you can potentially engage in, as there are so many other areas from which students can learn. They may be required in some programs and voluntary or absent in others. So these may include things like book groups, journal clubs, guest speakers, webinars provided by outside organizations like commercial genetics labs. You could join some special interest groups by becoming a student member of NSGC. You can also request extra or different fieldwork rotations to expand your knowledge and experience. Most program leadership members are very open to suggestions for these kinds of supplemental activities. So you want to be creative and ask for what you want. You will likely be pleasantly surprised. I'll give you an example. We've had a few students over the years who said, I really want to do psychiatric genetic counseling, and that's a really difficult thing to find. There are just not a lot of psychiatric genetics clinics in the country, and that's probably largely because the genes for psychiatric illnesses haven't been discovered, cloned, tests made available for them. And so it's all counseling. It's no genetic testing, but we've had students who've gone out to Vancouver for a few weeks to the first and to date one of very few psychiatric genetic counseling clinics in the world. So, you know, there are other kinds of things you can apply for, lab rotations. And, you know, I know in our program, our students are required to do 30-day rotations in a semester. But if they really want to do, let's say, cardiac genetics, then we can shave it down a little bit such they can do 20 days in a cancer center and then the other 10 days in the cardiac clinic, things like that. So again, if you want something, ask for it. They may very well be able to accommodate your request. And then the last thing I really wanted to touch on is the very deep emotional components of our profession and the rigors of training for it. And because of all of that, we feel it's really important to care for yourself, as it always is in life. So as part of a training program, whether it's actually embedded in the program or something that you do on your own, we feel that self-care is very important. It's easy to get kind of pulled under sometimes by, again, the emotions of our sessions with patients, your stress regarding coursework or rotations, interactions with classmates and colleagues. So it's an important thing to take care of yourself, as it always is. And it can take many forms, of course. Maybe your thing is to meditate or do yoga or cook or be with family and friends. Some programs build it in, and some will expect you to care for yourself in your own way and in your own time. I know in our program, especially because it's online and our students are not physically together, they have created movie nights and game nights and other kinds of social events. And when we do have our students together on campus once or twice a year, we always build in some time for socializing and decompression. But of course, that involves the students being with each other. And sometimes self-care requires you to be alone or to be with people who are completely disconnected from the pieces of your lives that are creating the stress. What you do is not as important as the fact that you're doing it. And we feel strongly that this should be part of everyone's graduate school experience. And in fact, when we interview students or applicants, we ask them what kinds of self-care they engage in. So something to think about. I'm not saying that other programs ask that question, but it's probably a good thing to have in your pocket. If they ask you, how do you take care of yourself? You want to have some kind of answer, and hopefully it'll be actually something that you practice on a regular basis. So that's what I wanted you to know about what to expect in graduate school. I hope you will feel free to reach out to me at any time with questions about genetic counseling training programs in general or BayPath's program in particular. And I welcome your questions.
Janice, that was great. And I love the self-care bingo. I'll have to steal that from you.
You can find any graphic online. I liked it too.
But I know that there were a couple of questions that have popped up in the first half of the session. I think I'll wait to ask them until Maria has given her talk, and then maybe you two can address them in tandem.
Sure, yeah.
So I'm going to switch it over then to Maria. Let's see here. Perfect.
All right, great. Let me see my screen. Great. All righty. So hi, everyone. Thanks for coming and sticking with us through the afternoon. My name is Maria Gyure. I am the program director for the UConn Genetic Counseling Program, as well as some other graduate programs within the UConn family. So I wanted to chat with you a little bit today about applying to programs and how to strengthen your application. It can be quite an intimidating process, as some of you may have already experienced. So I kind of wanted to go through a few steps and how to start that, and some of the questions that you might want to ask yourself as you're thinking about what programs to apply to. So step one of this process is to know yourself. You know, genetic counseling has lots to offer in terms of a career, in terms of kind of a life choice, but you want to make sure that that choice is right for you. So really take some time to reflect on what's important to you, what makes you tick, and what do you think will be fulfilling in a career in general. And sometimes the best way to do this is to talk to people. You know, being here today is a great start. And I think you've probably now met some folks that you could reach out to question and ask and maybe have conversations about the career. But that's really a good starting point, is to kind of do your due diligence in terms of what you as a potential applicant are looking for. So step two, so once you kind of determine that and that this is the right step for you, is to know the programs. So As you've heard, there are many programs throughout the country and Canada, and although they're very similar in the fact that they're held to specific standards by our accreditation agency, many programs have their own strengths or niches. Some really stress psychosocial skills, for example. Some are really big on research or technology, or, it might be important to think about the types and amounts of clinical exposure that each program has to offer. What are the patient populations based on where you are or where you would be? So I encourage you to do your homework around that. There's a lot of different ways to choose programs, and we're going to talk about that, but just know that not all programs are created equal in terms of what they want to emphasize to their students. So when you're at the phase of wanting to select a program, what do you do? So there's lots and lots and lots of different things that are important and things that go into the formula of what makes somebody want to apply to a particular program. So these are just some things on the left that could be questions or checkboxes for you to think about, or things that could be important to someone. So first is education delivery. There are different types of programs in terms of whether they're face-to-face, whether they're completely online. Do they have a hybrid modality? So that might mean you go to campus sometimes, but not all the time. And how does that play into class size? Like, are you someone who likes to be part of a larger group, or do you like a smaller class size? I had 3 classmates when I went to graduate school, so it's very different than some of the class sizes that are out there today with 22, 24, upwards of 30 students per cohort. So is that a deal breaker for you, or is that something that makes you gravitate toward or away from a program? Cost is important. So tuition and fees obviously plays a big role into which programs you might want to select. Are there scholarships that are available to help alleviate some of those costs? What is the cost of living within a program and where it's located? This can be a huge deterrent, an attraction based on whatever your particular financial situation is, but it's important. And tuition and fees, potential scholarship availability are things that a program might have online, so that you can kind of do your homework and your research by going to each of the websites of the programs that are of interest to you, and you should be able to glean some really good information regarding cost straight from their website. Location is important. So similar to cost, it tends to be a biggie in terms of why applicants choose particular programs. Maybe you're someone who likes a more urban setting or a more suburban setting or very rural. There are programs that kind of check all of those boxes in different places. Do you need a program that's close to family or friends for whether it be support systems or for living arrangements? Do you have to travel for field work? Is that kind of within the bounds of public transportation? Do you need to have a car for campus? So these are all questions that are logistically important and necessary to consider when you're thinking about a program. I will kind of put a plug in here for, yes, location is important, but if a program ever asks you, why you chose them as a program over others, like, please don't ever say, oh, it's because my aunt lives here and I want to be close to family, or I just always wanted to move to Boston, or things like that. So while they're important, they tend to be your personal reasons. So make sure that that you can make your choice accordingly, but also relay that appropriately. Faculty are important. So who's going to be your instructors and who's going to be your mentors and advisors are very important. And while you might not know who they are specifically before you get there, it can be important to research what is the faculty to student ratio. Is the class so big that you don't get a lot of engagement from your faculty members, or is the class so small that you're hearing from them all the time? This comes kind of down to personal preference and what you feel like you need to be successful in your graduate education. Affiliations are also important. So these are collaborators that your GC programs will have made relationships with, and these can include other universities or colleges. Are they part of a medical school? Are they part of a university-based hospital? Are there international partnerships? So there may be some places that you're hoping to train or hoping to get some exposure to, particular industry partners or laboratories. So it's important to look at the different collaborators that programs have and the different affiliations and where you rotate. So that kind of brings me to training opportunities. While Janice talked about having, kind of the big 3 rotation of peds, prenatal, and cancer, what does that look like within each program? Are you going to get all of your education kind of within one university-based hospital? Do they have their tentacles out larger where you can experience different patient populations? There are different hospitals and specific clinics, and there are specialties. Do you get exposure to something like advocacy or community outreach, or maybe public health is really important to you? So there could be a lot to unpack in the training opportunities. And again, this all comes down to what you want out of a program. So as much as they would be, interviewing you and asking you questions, these are the questions you want to ask of a program and kind of to yourself before you get there to make sure that that program would be a good fit, should you match with them. So once you kind of have your list of programs that may fit your needs, and I've seen a plethora of lists from students. I've created my own. They can look like very elaborate spreadsheets sometimes in terms of prerequisites and where they're located and how much they cost and things like that. So whatever's important to you, make sure to put that on your list. But the ways that you can explore programs can vary. So you can first review websites, and I think that's a great place for everybody to start. I put the website here for the accreditation agency that lists the program directory. So you can kind of look by state for who is currently accredited and accepting students. You can visit campuses, and I understand that during COVID, obviously sometimes this makes it difficult, but you can always have a virtual tour or virtual visit. Emails and reaching out to program directors and other faculty and program leadership is helpful. So if you can explore the area, if it's a new town, just to kind of get a feel for whether you like that type of a setting. I completely understand that this is could be very cost prohibitive, but I think once you narrow your list down to just a few, visiting and exploring a campus in itself is worthwhile. Engaging students and alumni. So again, some of the most important information you can glean from this process could be to speak to current students. And many programs will have a student representative, generally a second-year student who has already gone through the program for the first year, who has been able to develop an opinion on some of the pros and the cons and what would they do differently and how happy they are. And generally these conversations can be very, very helpful. So I encourage you to reach out to students or folks who have graduated from a program and ask them their experience. So the last little bucket here is to ask questions. And these are some of the questions that you might want to ask a program to help give you the information that might help you make a more informed decision. So for example, what do programs emphasize in terms of educational content and delivery? So this is kind of like what makes your program special, and then how do you disseminate that information to students? Is it all online? Is it kind of hand-holding? Is it throw you in the deep end? You could get a variety of answers here, but I think all of it could be very, very important. And obviously you want to know what the strengths of the program are, what are their kind of accolades and accomplishments. And I think that's important to be able to consider in making your decision of how, what a program's been able to do with their time while they've been a program. So, okay, so step 3 is to know the process of the application, and there's quite a process. So while most programs are similar in terms of their requirements, they're not all the same. Some require 1 semester of organic chemistry, and some might require 2. And, so this is, again, where your spreadsheet might come in handy if you have created one, to kind of list out what the prereqs are for coursework. Timing for applications is important because the deadline for submission for applications is not the same throughout each program. So some may have a deadline of November 30th or December 15th or January 1st or February 1st. So it really can go throughout that whole winter time. So make sure you are well aware of what your timelines are. So applying to more than one program, I put that here. It feels ironic to say because I only applied to one program and I got into my program, but that is not the norm. I think some of the studies show that people who apply to 4 or more programs are statistically significantly more likely to gain entrance into a program than if you applied to one or two, which makes sense. But so I think in terms of how many programs to apply to, there's things to consider in terms of cost and time and effort and letters of recommendation, and all of that goes into it. But I think the typical applicant will apply to at least a few programs. And now with interviews being virtual, that does help with cost. It used to be that you'd have to fly everywhere to go to your interview or find a hotel or stay with a student, make arrangements, take time off of work, things like that. So I will say that, one of the only benefits to COVID is that it has made the interview process more accessible to more applicants. So we chatted about cost a little bit. So there are costs associated simply with applying to programs. You have the match fee. So I don't think we really touched on the match yet, but it is something that all genetic counseling applicants will have to do, is register with the match. And I think the match is about $100. Some programs do have waivers for fees for applications. I think that the match system NMS has potential waivers for fees for the match as well. So be able to investigate where those incentives or alleviations might be. And again, interview expenses can be costly if you have to travel there. So it's a process. So understand it's a process, and we all as directors understand it's the process and do have empathy for that. So this is a very busy slide. It has lots and lots of words on it about application requirements. The important thing to know is that this is not an exhaustive list. So there is lots and lots and lots to do when it comes to an actual application and things to consider. So do you have all of your prereqs in order by the time that you apply? Know that for some programs, you have to have all of your prereqs on a transcript prior to submitting your application, or it has to be prior to the interview process. So there are different timelines even for things like that. One caveat to note is AP courses. And in general, if you took, AP psychology in high school and got credit for it and didn't take a psychology in undergraduate, then it generally won't fulfill the requirement for graduate school to have that level of psychology. So I get this question from students a lot. And again, every program is different in terms of the decisions that they make. So this is all general information. So typically AP courses won't be accepted to fulfill prereqs for GC school. The GRE is becoming a little bit less and less required from programs. So what I've seen in the past few years is a shift where in the past, every single program required the GRE to, just a couple were outliers where they didn't require the GRE. So if you were going to apply to multiple programs, you kind of had to take the GRE because chances are, at least one or two of your programs would require that. That's not becoming the case. So I definitely encourage you to look at that piece of the application process or requirement within the programs that you're considering, because now it does vary quite widely in the terms of the numbers of programs that are no longer requiring the GRE. Language requirements are still fairly standard. So if English is your second language, there are going to be requirements based on school in terms of what they will accept for, example, TOEFL scores or a writing assignment, things like that. They may differ from university to university, but they generally will have some type of language requirement. You're going to have to submit transcripts. You're going to have to submit your GPA. I have some shameless plugs in here of the clinical genetics and genomics certificate that I run at UConn, as well as the clinical communication and counseling certificate that I run at UConn as well. These are a set of courses which can gain you a graduate certificate in these areas, which a lot of students join and apply to these programs in order to boost their GPA. So I tend to get the question of what is the golden number for GPA and what do I have to do? And this varies widely for programs as well. Some will come out and say what they will and will not accept for a GPA. Some are a little more ambiguous, and some programs are moving to a more holistic space of not relying as much on GPA as they are trying to look at the applicant as a whole. So, but for people who are interested in, taking more graduate level courses, which are related to clinical genetics specifically, or the psychosocial piece, which is the communication certificate. These two certificate programs are available through UConn, and many students go on to genetic counseling graduate schools from these programs. Letters of recommendation, usually it's about 3. You want to kind of have the trifecta of letters of recommendation. So, you want to have someone from academics who can speak to your academic prowess and your potential for success in a graduate program. If you've done research in undergrad or as a position that you hold right now, research is a good letter of recommendation from a PI. I have folks who have advocacy and outreach experience. So kind of the counseling portion of the genetic counseling hat. That's a good, another base for the triangle there to have. You want to have basically a well-rounded list of letters of recommendation. Do not ask family, do not ask friends, do not ask peers really to assess you and give you a letter of recommendation. It's not as professional looking, it doesn't carry as much weight, and you want to make sure you really only get like those 2 or 3 letters. You want to make sure they are from folks who can really speak the language that graduate programs need to hear and say the things that they need to say. A personal statement. So I get a lot of questions about personal statements and a lot of students who are looking for assistance with this. This can be your time to shine. This can be your opportunity to be able to say what it is that makes you different from other applicants. So please, please, please take this very seriously. Don't challenge yourself to write it in a weekend. You should be going through multiple drafts of this. You should be going to a writing center if you have access to one at your current university. If not, there are actually places online that you can send your statement to get edited, to have questions asked, to help you with rewrites. So I encourage you to really, really, really take the personal statement piece pretty seriously, because that can be what sets you apart from somebody else. Volunteer experience is important. They want to see that you've had experience putting on that psychosocial hat. Crisis counseling is very common for applicants to have, or bereavement counseling, support groups, working with the disability community, all types of these things that could be local to you, or they could be virtual now in times of COVID. Basically, what you want your application to show, all in all, is that you've done your due diligence in terms of investigating the profession and knowing that this is a right fit for you. So everything that you do with a purpose. And, shadowing or interviewing genetic counselors is wonderful. It's not required. Shadowing is becoming increasingly impossible to find in times of COVID. So just please don't be discouraged if you don't have a shadowing experience prior to application. We as programs understand that it's very difficult to get that type of experience. There are other ways of kind of seeking that information. You could call a genetic counselor and try to interview them or talk to them. There is a Master Genetic Counselor series, which is a set of videos that are free to watch through the National Society of Genetic Counselors, NSGC, which shows examples of different genetic counseling settings. It's role play, with actors and actual genetic counselors. So you can see what an actual session looks like. They have prenatal and cancer and peds, I think, I think they have all 3. But they're about a half an hour a piece, and they get digested afterwards for questions and things like that. And it's really another great way to kind of get some of that experience. All right, so one of the last steps here. So you're going to listen to my father. Here's a picture of my dad. He's holding my son. That's Nicholas. And my dad always said, if a job's worth doing, it's worth doing right. So that means if you're going to go through this process, and it is a process, it's big and it's overwhelming at times, that you want to put your whole everything into it. Okay. So you're going to do your best when it comes to that personal statement. You're going to make sure you check off the boxes for prereqs well before you have that application. You're going to make sure that if you don't have volunteer experience, that you're not doing it just a month or 2 right before your application process. You have to show them that you're really invested in this career path. So no half-assing anything, do everything to your best of your ability, and it will show in your application. Those are words from my dad. So lastly, I'll leave you with some helpful information. This relates to, I think I saw a couple of questions about this, potentially taking a gap year. So for some students, they feel like it's looked upon negatively to have a gap year. I'm here to tell you that it is absolutely not looked down upon to have a gap year. You know, for students who take that gap year or longer, I took longer, you know, that means you might actually be in a professional setting. So you're gaining professionalism, you're gaining experience in the field if it's related, hopefully it's related. You know, you're saving money so that finances don't become such a burden. You know, you're doing what you need to do to prepare for grad school. So taking a gap year, not a bad thing at all. If you go through this process and you don't match, it is disheartening, obviously, and disappointing to have that happen, but you are not alone. This is very common. There are many, many, many applicants for not a lot of spots. So if you're not accepted, please, please, please reach out to the programs that you wanted to match with and get feedback. You may think, I didn't get in because I didn't have a great GPA, but maybe it had nothing to do with it. And it was the fact that you didn't have enough volunteer experience, or your professional or your personal statement just wasn't up to par. You know, so just please seek feedback so that if you decide to do this again, you can work and make the right strides to getting in. Contact programs to make sure you're fulfilling their requirements. So if there's ever a question when you're going through the application process of like, ooh, I don't know if this is going to count or not, don't just wing it because it might not count. Please feel free to contact programs. There are folks who can answer those types of questions very quickly. So you'd hate to kick yourself later for being like, oh, I just didn't know that. And again, familiarize yourself with the profession. So this is you doing your homework and doing your due diligence. You know, review the NSGC Code of Ethics, the position statements that they put out, the policy statements that are written. Be able to have an intelligent conversation about some of those things should they come up in an interview or when you're talking to a genetic counselor while you're interviewing them. Read the genetic counseling literature. So lots of things come out about genetics right now, and it's very important to kind of stay abreast of that. And that actually shows that you're very passionate and invested in the profession. Again, the Master Genetic Counselor videos at nsgc.org are free and they're available and they're wonderful. So I encourage you to do that. You can do this. It is hard. I know it's hard. It's a lot. There are a lot of pieces that go into this, and it's a long process. But stay positive, keep working hard, and you'll make it happen eventually. So if you have questions, I'm available. That's my email. Feel free to reach out. I'm always happy to chat with students, potential students, applicants, whatever, and answer any questions that you might have about the process or programs and so on and so forth. So thanks for your time. I hope I didn't go too long. I tried to speak very, very fast, and I'm happy to answer questions at the end.
Thanks, Maria. That was really inspirational. I feel like I'm ready to apply again, round 2. But I feel like your presentation was almost like an FAQ in itself. So I'm going to just switch it over to Olivia and Kim. I appreciate if you could stay around till the end, but of course you did provide your email. So let's get this show on the road. Here we go.
Great. Let me just share my screen here. Okay, can everyone see this?
I think we're good.
Okay, great.
Okay, so I know we're short on time. So I am Kim Freya. I just recently graduated Bay Path University this week. So we're kind of here to talk to you a little bit about the graduate school experience and kind of what we went through in the last couple of years.
And I'm Olivia. I just became a second year at Bay Path's program. And like Kim said, we're just going to go over a little bit about our backgrounds, how we got into the program, and any little advice that we can give to kind of help you guys. So let me just go on.
Okay, so every genetic counseling student is definitely going to have their own unique background. Mine is a little different than I would say probably most of those that I've seen. My education background, I completed my Bachelor's of Science at University of Oklahoma. I worked on my bachelor's for over a decade because I was in the Air Force for 10 years active duty, and I was taking classes kind of 1 or 2 at a time while I was also working full-time in the military. I transitioned over into the reserve so that I could finish my bachelor's degree and then also apply and go through graduate school. So that particular piece, I would say, is very different than most students that I've met and experienced. Not many have gone through a military background. As far as volunteer goes, in my work as an Air Force member, I did a lot of crisis intervention counseling as part of my job, but I also did suicide intervention training. So I'm actually a trainer that does that program to teach others about suicide intervention. So that's another different kind of a volunteer experience. So I don't really have a very typical background as a student that's applying to a genetic counseling program, but.
So like Kim was saying, this is actually a great example. My backgrounds are very different from Kim's. So I have a bachelor's of science and a master's of science in infectious disease from the University of St. Joseph's. Kind of in between getting those degrees, I worked as a cancer clinical research coordinator. So I was enrolling patients onto clinical trials. I kind of focused on the Memorial Sloan Kettering Impact Study and the GRAIL study, which developed the new cancer screening blood test called Galloway. And after that, I did a medical scribe position at a asthma and allergy place. When I was there, I actually got accepted into PA school and did go, but I found out while I was there, it really wasn't for me. So that was like a big kind of twist in my journey that I would say that I wasn't expecting. So I actually took a gap year and kind of wanted to just really look over my experiences and kind of figure out what I wanted as a career, who I was, just kind of about my future. So I kind of was looking back when I was a researcher, and I remembered my interactions with a genetic counselor, and I really didn't know anything about genetic counseling. I never even heard about it. So I kind of did a deep dive into the profession, and I just kind of fell in love with it. So I decided to volunteer as a genetic counseling assistant at a maternal fetal medicine, and kind of really got to learn the role of the genetic counselor, and really just could see myself doing this for the rest of my career. So I decided to kind of build up my resume so that I could apply. And it was, like I said, my gap year. So I kind of wanted to do something that was of interest of me, something that I've always wanted to do. And now that I had the time, I decided to volunteer at an equine assisted therapy program. And I'm a lifetime horseback rider, so it was really just a passion of mine. And I decided to really help those. We were doing frontline workers at the time during the pandemic, and we also did veterans and children with autism or other disabilities. So they would take us on trail rides, and we would just teach them about horsemanship. So it was just something that I really was passionate about. And while during the pandemic, I also decided to do like a virtual teaching program. So I taught immigrants and refugees English as a second language, which was brand new to me. It was very challenging, but I really loved it. And kind of just what Kim was saying, these were things that I was passionate about, and I like thought they would look good on my resume, but that really wasn't why I was doing it. So I would just kind of encourage you guys to do things that you're really passionate about, have like a really good interest in, and that kind of makes you unique in your application. So that's just what I wanted to say about that. And that's pretty much my background. So Kim and me wanted to just do another slide about, advice for you guys getting into the program and during the program. So I'll let Kim take over.
Yeah. So, graduate school is definitely not for the faint of heart. I don't think it really matters kind of what degree you end up going into with like getting into higher levels of education, graduate school, PhDs. It's going to be a lot of work. It's going to take a lot from you. And so, like Olivia said, doing things that help set you up for that kind of thing, that you're passionate about really makes a difference. Going into those graduate school interviews, saying I did these things because I really like them and I know a lot about myself, and I know that this career is going to be for me because I know that it's going to be something that I am passionate about, and why that is can really help kind of key into to those that are interviewing you, that you've really thought about it and you really kind of know a little bit more about yourself than maybe when you started. I would also say that highlighting kind of what makes you unique is a really good aspect in getting into graduate school, and also going through your clinical rotations and those kinds of things. Being able to, again, know yourself, help yourself stand out a little bit from what other people make them unique, so you can really stand out in the minds of those that are interviewing you, those that you're working with. It definitely is a asset and not something that's a hindrance. And then also graduate school, like I said, it's a lot of work. It's a lot of time management skills, going between didactic work and your clinical rotations and being able to do your capstone or thesis all at the same time. Sometimes it's a little disheartening where you feel like, why did I get into this in the first place? Can I really do this? Is this really what I want to do? Trying to have those little reminders about why you decided to do this in the first place can really help push you through some of those really rough days where you're really like tasked to the max with case prep and also getting an assignment done or an exam done. And then also, by the way, your thesis professor is going to say, hey, have you done this part for your thesis yet? You should probably really be thinking about that. You can have a lot of things going on at one time. So being cognizant of why you really want to do this can really bolster your energy and your motivation to keep going and to keep trying and to give yourself confidence that you really can do it. Because you can. Everybody can. They, if you get to the place where you've applied and they've accepted you into a program, they can see that you can do this and they have faith in you. And that's why they accept you into the programs, because they feel like you're ready and they know that you can do it. So keep that confidence up.
So for mine, I just, I guess because I'm a second year, I still remember applying and being actually doing this program last year as an applicant. So I just want to say, don't compare yourself to anyone else. I think a lot of times when we do these webinars and the students talk about their backgrounds, a lot of applicants tend to think, well, I don't have this, or I didn't do this, or should I do this? And it's just everyone has their own journey. Like me and Kim are a good example. Like we are very different in our backgrounds, but we both made it into the program. And she graduated, I'm a second year, so we're definitely doing it. So just don't compare yourself. We all have our own strengths and weaknesses, our own unique abilities and experiences. So really, like I said, just, do things that you really enjoy and shows who you are as a person. And I think that will make you a really strong applicant. So just, don't compare yourself to anyone. I think that goes along with even in the program. I think a lot of times we have imposter syndrome, like, did they really choose me? And I think I still have that a little bit. So just remember that if you do get in, you are there for a purpose. And if you don't, it's really a numbers game. Like there is limited spaces and limited programs. We're all really qualified. It's just sometimes you just have to up a little bit. And like I said before, like talk to your program director or any interviewers and see like what you can do to improve your application, because most of the time you are qualified. It's just a numbers game. And then my second one, and Janice already touched upon this, is just self-care. And Kim, like Kim said, it can be a really stressful program. But it's worth it in the end. And I think to able to get through the program in one piece is really self-care. You gotta have to remember why you went into it, in the self-care of just doing anything that you enjoy, whether that's going for a walk, reaching out to friends, taking 20 minutes a day, maybe taking a couple hours off during your program, just anything that will keep you a little bit like yourself, because like Janice was saying, you can really get in the undertow and kind of forget about that. So just self-care is really important during the program. And while we're teaching right now, they're teaching us about compassion fatigue for genetic counselors. So I think that's really important going into the career as well, to take care of yourself. So I think those were just our advice. Kim, do you have anything else to add?
We're super happy to have you guys contact us. That's why we're giving you our email. Please use it if you have other questions. This is a very short amount of time to be able to explain such a complicated thing. So please feel free to reach out to us.
Yes, definitely. And I'll stop sharing now.
Thank you both. And Kim, congratulations on graduating, making it to the promised land, and hang in there, Olivia. You'll be there in no time. But I might share my screen to go over, where did that go? The emails for our great panelists. Thank you again so much for taking the time out of your day to share your insights and thoughts with our attendees. Let's see, y'all can see that. There were a couple of questions. I wonder if there was anyone on the panel who had last minute remarks to make to our group here before we close for the day, as I kind of look through these questions. Okay, Maya or Emily, are you guys still on?
Yeah.
Okay, there was a question from earlier about deciding whether you wanted to continue working in the lab or exploring multiple specialties, or if there is anyone here who has kind of transitioned from one specialty to the other, if you could just comment on that.
Yeah, so for the time being, I really don't know if this is something that I want to stay in long term. I like it right now, but I also like the fact that I've been offered the opportunity to start seeing some patients. It will only be, I believe, 2 days per month. So it will be limited, but it will be nice to actually get back into the clinic and see people. But as far as long term, I don't know. I do find it rewarding in its own sort of ways, but it is different.
And I probably will stay in lab for my whole career, but one of my favorite things about GC is if that does change, I do have the opportunity to go to a different specialty.
And anyone who might have taken some time between their undergrad, between that and graduate school, how did those jobs or your experience during that time prepare you?
I can maybe provide an answer to that, if that's okay. So personally, I had taken 2 years off in between undergrad and grad school. I did not know that I wanted to be a genetic counselor when I was in undergrad. I think I'd heard of the profession, but not known enough about it to consider it seriously as a career. I personally majored in psychology and had a minor in biology. So in between, going back to school, there were like 2 other classes I think that I had to take. And I did those at like a local community college because of money, of course. And in the time between, in those 2 years, I worked primarily in mental health. So I worked with individuals in a mental health center and also with some individuals with disabilities such as cerebral palsy. And I actually volunteered to help teach a kind of an art class for these individuals with disabilities at a day center, kind of an art class, modified to their levels. And I definitely think that working with individuals with, various mental health issues, cognitive and physical disabilities, even though it wasn't specifically related to genetics, was actually enormously helpful for me, I think. Just moving into those, kind of needing to put on the counseling hat, so they say, when working with patients.
Excellent. There was a question for Emily and Maya. What do you find or a difference between pursuing a master's in genetic counseling and not a PhD in, let's say, genetics or lab work?
So I find that they're pretty different. Pursuing a PhD in genetics, depending on if it's molecular genetics, which I think is most likely what you're asking about. It's a very different sort of course. Genetic counseling is much more focused on the interaction with people and looking at their different sort of clinical symptoms versus if you're going into molecular genetics, it's much more about the DNA itself. And I find that they are very different, just because they really focus on different aspects of genetics. They do have a lot of crossover, but they're fairly different fields.
Great. Okay, well, as people are dropping off, ready for the weekend, any last comments? Thank you all again for attending and speaking. That was really, really, really informative and helpful. Okay, great. Well, this recording will be available after that short survey, so I'll send that out in the coming weeks. I put in the contact information for our great panelists today, but you can always reach me afterwards. And if you have a more specific question for a panelist, I encourage you to contact them directly. But thank you all so much again, and have a great weekend.